simple, powerful framework for understanding why we do what we do and how to change it. So what is the COMBI model? COMBI says every behavior depends on three things coming together at once. Whether you are able to do it, that is capability, whether your surroundings let you do it, or whether you actually want to do it. That's motivation. This is COMBI. This is used very extensively in psychiatric, medical, and everywhere in fact. So, I don't know. So, one should have a physical or a psychological capability. The physical capability, the physical strength, stamina, dexterity or skill needed to perform the behavior. And psychological capability, the knowledge, mental skill and thinking ability needed, remembering, planning, understanding and self-regulating. An opportunity, there is one physical opportunity factor outside the person, time, money, location, resources, access that make behavior possible. So if there is a shop, Taskmark shop nearby and then you have the capability to buy the alcohol, you will develop that habit. So even to get rid of that, and opportunity should come. Social opportunity, cultural norms and social cues. So if somebody has every weekend there is a party, then naturally they will become an alcoholic. This is applicable to almost all the habits. And motivation. One should have a motivation, conscious plans, goals, evaluation, and automatic motivation, emotions, impulses, habit, reflexes. So if all three come together, one develops habit, and to get rid of this habit, change in habit also, there should be some influence in everything. So example, I want to exercise more. So do I have capability? Do I have a beginner friendly routine and does my body handle it without an injury? Opportunity, is there a safe place nearby? So our job is to tell them, if the patient says that, a person says that I don't have a gym nearby, I have to travel far off, we should teach them some exercises which can be done at home. And motivation, of course, if we tell the benefits of such a behavior change, they will do the motivation. So it's used in public health, education, workplace, policy design. If you search the AI for this, it will give what are the habit change, what is the benefit in as far as diabetes is concerned. How do we educate a patient? How do we make them do the exercise, take the correct food? That will be given as an example. Why I brought this? Because this month there is a review article in American Journal of Gastroenterology, and it talks about the barriers and facilitators of alcohol use disorder and in treatment for associated liver disease. There is a systematic review. It's a very beautiful article which deals with what we have to do as far as alcoholics are concerned. How do we get rid of them? This is this month's American Red Journal's article. There are many methods. I don't want to go into the detail. And so next time a habit isn't sticking, ask which piece is missing. Check your capability. Do I actually know how, and am I physically ready? If not, learn, practice and build up gradually. It may be for weight reduction, it may be for diabetes control of alcohol, or developing a new habit in a reading habit. And check your opportunity. Does my environment make this easy or hard? Rearrange your space, time and social circle to help. Check your motivation. Am I relying on willpower alone? Connect the behavior to something you genuinely care about. Small changes to just one circle can be enough to tip the balance towards an action. Thank you.
Next, we move to the postgraduate sessions. I hope more postgraduates will join. And I'll ask Dr. Deepak, the chairperson, and Dr. Sangameshwaran. Please, I think he's on the way. So, to chair the session and conduct the proceedings, please. Deepak, come on.
At the postgraduate session, the first will be by Dr. Anirudh from Gen Hospitals with the topic Under Pressure, Managing a Case of Blown Out Myotomy, a Late Complication of LS Myotomy.
I am Dr. Anirudh from GEM Hospital and first year RNB. I'd like to present this case, a case of blown out myotomy, which is presented many years after the original LS myotomy was done. My guide is Dr. Vinod sir, who did the procedure. So basically, brief details about the case. This patient is actually 18 years old. She was pediatric history is relevant, so I'm just covering that in brief. A firstborn child to a third-degree consanguineous marriage with normal normal vaginal delivery with a normal birth weight, who had initial global development delay in motor milestones as well as language milestones, but by the age of 3 years she had caught up. In 2011, at the age of 3, the patient presented with dehydration and hypotension to an outside hospital. She was diagnosed there with adrenal insufficiency, which was non-responsive to ACTH, and pituitary hormones were otherwise normal. Ophthalmologically, she had a convergent squint as well as alacrimia. In the gastrointestinal aspect, which is relevant to us, progressively for a period of 1 year to 1.5 years, she was having dysphagia, and initial barium swallow done at that time showed a motility disorder. With this triad of achalasia, adrenal insufficiency, and alacrimia, the preliminary diagnosis of Algrove syndrome was made. She was given steroids, nifedipine, and discharged. Shortly after that, high resolution manometry showed features of type 2 achalasia. So at the age of 4.5, she underwent Heller's myotomy and Nissen's fundoplication. Following that, for about a period of 2 years to 2.5 years, she had good improvement, but she didn't gain weight. Following that, for the next around 5 to 6 years, she continued to have complications. For repeated exposure keratitis, she underwent tarsorrhaphy. In 2014, she had another admission for adrenal crisis. In 2019, she had multiple dental infections, so she underwent dental extraction of around 6 teeth. In 2016, by this point, dysphagia had come again, and she was not able to take much per oral, so she had a feeding gastrostomy placed. In 2021, repeat high residual manometry showed high IRP, so she underwent pneumatic balloon dilatation. Following that, again she had only brief period of improvement of symptoms, maybe around 1 year, but throughout she has not gained weight. She was continued on steroids and conservative management. In 2023, she was having a lot of pain at the gastrostomy site, so the gastrostomy was removed. In 2024, because of steroid-induced, she had multiple vertebral compression fractures and underwent vertebroplasty for the same. In 2026, from 2025 onward, progressively the dysphagia was worsening and she was having meal-related pain, so she presented to us. An additional point I'd like to notice, she attained telarchy only at 17, pubarchy at 18, and still has not attained menarche. So she, just to give you an idea of the problem, this was her growth chart maintained from young age. Height for age was always below 5th centile or 5th standard deviation, 6th standard deviation. Same for weight. Even until now, she has not crossed 20 kilos of weight. So Eckhart score at that point at our presentation was 8. So severe achalasia. So we preliminarily did an endoscopy. Endoscopy was showing some amount of food stasis. The fundoplication wrap seemed to be intact, and there was a large diverticulum-like structure just above the OG junction. In little later on, I will show the video, which will give a better idea of what we were dealing with. So we proceeded with high resolution solid state manometry. Just two things I'd like to highlight in this. First is 100% failed peristalsis and a very low IRP. Even though she was having dysphagia, she's having these symptoms, despite that it was an adequately treated achalasia. She only had an IRP of around 2. So we made a preliminary diagnosis of a possibility of a blown out myotomy, which normal IRP with no, failed peristalsis, but anatomical defect we wanted to consider based on the endoscopic finding in this. So we proceeded with the barium swallow. So barium swallow was showing distal ballooning of around 15 millimeter with the proximal esophagus being around 10 millimeter in length, and the entire segment was around 2 centimeters long. So based on TRIGS criteria in 2021, the preliminary we could make a diagnosis of blown out myotomy. So what to do next? So Patty et al. Made in 2022 gave a criteria of how to approach these kind of patients. Initially, the workup was done for post-myotomy patients, but if these patients have recurrence of symptoms, how to evaluate and how to go about it. So what we did first is we used our Eckhart score and found that burden of disease is significant. Then we proceeded with time barium swallow and endoscopy. Time barium swallow was showing around a 5-minute hold up of contrast quite significantly, and we classified the disease. So what to do next? What to do from here is first, what they've advised in the paper is if the original Heller's myotomy surgery video was available, to look at that, because usually this is more significant for early dysphagia, early recurrence. So in that case, migrated RAP or an incomplete myotomy is the most common cause. Then by endoscopy, we have to look for fundoplication disruption or features of reflux esophagitis or hiatus hernia, something else that may be contributing to the symptoms and not necessarily related to recurrence of an achalasia. So what to do next? So options from there, basically from the same paper, they advise that the initial thing should be endoscopic dilatation. Even if the improvement is temporary, if by endoscopic dilation patient is having an improvement in symptoms, then a more permanent solution will give benefit to the patient. If endoscopic dilatation itself is not giving benefit to the patient, then we need to reinvestigate the cause of the dysphagia. So one thing they notice, this it is destined to fail if the patient already has sigmoid achalasia, sigmoid esophagus, or hiatus hernia, or significant reflux esophagitis, or failed fundoplication. In that case, you should consider other options. So what are the other options? First is redo myotomy. The advantage of redo myotomy is extensively it has been done before. POEMS is a relatively recent procedure. For the last 15 years only we have been doing, whereas myotomy has been around for a long time. It will also allow us to assess the anatomical structure and see if we need to reassess the RAP, if there's a hernia, hiatal hernia repair, all that can be done. The problem is if this second myotomy also fails, the dense adhesions will make it very difficult to proceed for esophagectomy or any other definitive procedure or cardioplasty or anything like that. So we considered POEM for this patient. Since the original procedure was done with myotomy and we were not sure about the details, and this patient also has what features suggestive of blown out myotomy, we considered rather discuss with the patient about the possibility of short segment myotomy. The advantage is that our center is doing a lot of POEMS procedures, so we have good experience with regard to that. And worst case scenario, if this POEMS failed also, we have the option of surgical management thereafter. Studies by Akimoto in 2022 showed that POEMS compared to myotomy is equally efficacious in resolving symptoms, but also has lesser short-term complications, length of hospital stay, as well as incidence of bleeding, and less progression to esophagectomy. So this paper by Baraki in 2025, basically in patients who have achalasia who have been treated, what is the cause of achalasia and what to consider. So for this patient, we did esophageal manometry and we identified the morphology. For us, the IRP was already low. If there's a high IRP, we would consider improperly done or incomplete division of the sphincter. If there's any motility disorder or contractility issue with provocative maneuvers, if anything was suggestive of this, nothing was there. So we considered adequately treated achalasia rather than a treated achalasia with outflow obstruction. So in this treated achalasia, there are two possibilities. One is pathological reflux or altered anatomy. Since we had features to suggest an altered anatomy, we considered the diagnosis of BOM. So then we proceeded with POEM. So initial endoscopy was showing a large diverticulum-like outpouching just above the OG junction and very low failed peristalsis with some food stasis. So we proceeded with POEM. First raise the bleb, then make the incision and create the tunnel. Since this was a short segment POEM, we only went around, the tunnel creation itself was only 6 centimeters above the OG junction. So after tunnel creation, we proceeded to extend the tunnel until we reached this one. Periodically, endoscopy was used to check how far the tunnel had progressed. Then after the creation and delineation of the tunnel, we then proceeded towards the myotomy. We used a hybrid knife to go ahead with myotomy. Hybrid knife is advantageous in reducing the procedure time. It can inject, coagulate as well as cut with one instrument. The predominantly tunnel creation was through spray coagulation and soft coagulation. Cutting was through either soft coag or precision cut. Steadily proceed with myotomy until we cross the junction, until we cross the segment of lower myotomy and the this one just beyond that, and 1 centimeter into the beyond the LES. Once the tunnel was completed, you can just re-examine. You'll see that even initially itself, there's a good reduction in the volume of the almost 50 to 60% reduction in that anatomical correction was there. So using some hemo clips, we have closed the tunnel opening. So one Medora clip and some Olympus clips. With 3 clips, we were able to approximate the 2 ends of the incision. That's it. Okay. For post procedure, we did an oral gastrographin study to check for leak, and we found that the esophagus was completely collapsed and no holdup of contrast, and with most of the contrast material passing into the stomach. I don't have a video for this, but you can see the fully collapsed esophagus here. So after 2 months, patient came back to us. She is doing significantly better. While it's not prudent to do the Eckhart score so quickly, she had resolution of meal-related pain and meal-related dysphagia, but weight had over 2 months had not increased much. So that was the case. So I'd like to briefly go over to discussion. AAA syndrome itself was initially described in 1978. The triad is only present in about 70% of patients, namely adrenal insufficiency, alacrimia, and achalasia. Some people also call it as 4A syndrome because significant autonomic abnormalities also present. So it's an autosomal recessive disorder with the relevant gene AAAS gene, which stands for alacrimia, adrenal insufficiency, achalasia, neurologic, which is 12q13. Parental consanguinity and previously affected siblings are the biggest risk factor. While the exact incidence is not known, it's expected to be around 1 in 1 million based on published case series, but it's expected to be underreported. So there is a lot of heterogeneity in the presentation of these patients. It's the confirmatory diagnosis only through molecular analysis. More than 90% of these AAAS type phenotypes are related to the AAS gene mutation, but recently some papers have come out describing the GMPPA and TRAPPC. Around 6 or 7% of the cases may be associated with these gene mutations. So what is interesting about this case is there are no genes not yet described, or rather there's a small group of patients with none of these 3 genes, less than 1% of the 99% of patients other than these who present with AAAS like phenotype. So for example, our patient had no significant phenotype on genetic analysis, no relevant gene, so quite rare in that regard. In this one paper describing a case series, or rather a lot of patients with AAA syndrome were analyzed, and the phenotypes that were present are documented system wise. I've underlined what presentation our patient had. She had gait disturbance, pes cavus. She had the full spectrum of endocrine insufficiency, including osteoporosis with vertebral fractures and short stature. Dermatologically, she had palmar-plantar hyperkeratosis and hyperpigmentation with a dysmorphic facies and fissured tongue. She also had dental caries requiring dental extraction, as well as anisocoria also initially. What was extra significant about our patient is delayed puberty seen only in less than 5% of AAA syndrome cases. So that was an additional point for us. So what I'd like to highlight in this patient is what is our procedure, what we have done. Initially, there's maybe a few case reports coming out describing a new name for B poem in the same terminology as Z poem, as in Zenker's diverticulum poem. They describe for blown out myotomy a B poem. Some short cases have been done. They have maybe 4-5 cases have been described about how this BPOM could be equally efficacious to myotomy in treating blown out myotomy when compared to redo. So some literature, blown out myotomy itself around 6 to 18% depending on the case series and the experience of the centers can occur post myotomy. It can be early or late. The criteria has been described by Triggs in 2022, where about a wide mouth diverticulum at the prior myotomy site with a 50% increase in esophageal diameter and of a length more than 2 centimeters. The mechanism is basically it is thought to be related to either an incomplete distribution of the forces or incomplete division of the LES causing pressurization. Eventually that esophagus is no longer able to deform properly. Once that elastic deformation becomes a plastic deformation, it leads to anatomical changes. What happens is early BOM is usually related to fundoplication related problems or incomplete division of the sphincter, whereas late BOM could be related to the whatever has caused the achalasia in the first place. Progressive achalasia itself can result in this, especially in the site of division. One 2,400 patient study done in the initial in Japan showed that these type of complications in a series of POEM patients was found to be in the right lateral site, usually just parallel to or just next to the initial incision site. What they supposed is left sided because of cardiac cushioning may not be maybe supporting the esophagus and preventing it from ballooning. So because of the distribution of forces, the exact opposite side is where the blown out myotomy tends to happen. In our patient it was incidentally on the left side, but generally it may be on the right side in more than 96% of the cases. So what I would like to take away from this is achalasia is uncommon in the pediatric age group, and for a patient presenting with failure to thrive or high suspicion of reflux or regurgitation, achalasia should be considered and high resolution manometry should be given to the patient as soon as possible. The standard of care is Heller's myotomy and Nissen's fundoplication, but POEMs of the last 15 years have shown good results and good outcomes. So in these patients who have already undergone Heller's myotomy and are presenting with dysphagia again, POEMs could be a viable rescue therapy for these kind of patients. So thank you. I'd just like to, a small word, our institute GEM is conducted scope in the year 2025 and will be conducting again in 2027 between the June 18th and 20th at ITC, and please look forward to it in association with the SGEI. Thank you. If there are any questions or sir.
How will you differentiate between the epiphrenic diverticulum, which is more common between a blown out myotomy? Because a lot of Heller's myotomy done.
Yes, sir.
I don't think the blown out myotomy is that common. But epiphrenic diverticulum is more common. What you saw in endoscopy is the classical site for a epiphrenic diverticulum of long-standing achalasia. How to differentiate between epiphrenic diverticulum and blown out myotomy? Because both are entirely different.
Yes, sir.
So if you think something and treated that, it may worsen the
Yes,
condition.
sir.
So how to differentiate between these two?
Sir, it's a pseudo diverticulum, sir. So it may not be, it won't be a full thickness diverticulum. Even maybe on barium it should be visible. I think so, sir. I'm not sure.
No, we should read about how to differentiate between an epiphrenic diverticulum and a blown out myotomy.
Yes, sir.
Both exactly mimic like this, and there are differentiating features of both.
Yes, sir.
We should have an exact idea and differentiate both these and then go further.
Yes, sir. Yes, sir.
Because already this patient is having horrible time for so many years.
Yes, sir.
One more procedure should not make them more worse.
Yes,
That is
sir.
our main indication. And what is the best for the patient we should do.
Yes, sir. Thank you, sir.
So next will be presented by Dr. Praveen from SIMS Hospital with the topic "The Note That Opened the Pandora's Box."
Good evening, my dear professors and my dear colleagues. So I am Dr. S. Praveen from second year postgraduate DRNB Medical Gastroenterology from SIMS Hospital. So today I would like to present a rare case, and the topic of my presentation is the note that opened the Pandora's box. So starting with the patient profile, he is a 23 years old gentleman who is a postgraduate student hailing from Tripura, northeast of India, with low socioeconomic status. His initial presentation to hospital was in November 2024 when he presented with upper abdominal pain, jaundice and fever, and on examination icterus was there with per-abdomen diffuse tenderness, and he was evaluated in his hometown where amylase lipase was eliminated, and NECT abdomen showed hepatosplenomegaly with ginginitis. And when we did investigation, so it showed initially anemia in CBC with LFT showing derangement of direct hyperbilirubinemia with AG reversal, and transaminitis was there with elevated inflammatory and sepsis markers of CRP 280 and procal of 100 with viral markers showing negative. So we did imaging in him, and his MRCP finding which showed multiple peribiliary cyst. Which showed multiple peribiliary cyst with IHBRD, and in CBD there was dilated of 9 mm size with distal CBD defect filling was there with 5.3 mm calculate in the distal CBD, and you can see multiple para-aortic and the peripancreatic nodes was there. So with this we diagnosed obstructive jaundice with cholangitis as sepsis, and we proceeded with ERCP. ERCP splenectomy was done and complete CBD stone extractions performed, and followed by a 7 cm double pigtail plastic stent was placed, and the bile was aspirated and sent for culture, and the bile culture grew 2 organisms, Acinetobacter and vancomycin resistant enterococcus, and he was treated with injection tetracycline 100 mg BD. So following the course in the hospital, he developed progressive abdominal distension, and because of distension we did CT imaging to look at any other complication of procedure. It showed similar findings of hepatomegaly, peribiliary cyst with CBD in situ and multiple nodes. Along with that, moderate ascites was there. So we did diagnostic paracentesis, and it showed high SAG, high protein ascites with normal total count, and ADA was normal. But due to financial constraints, patient was not able to continue the treatment in our hospital, hence he got discharged at request. So later, but again patient presented to hospital almost 1 year the past hospitalization. He presented in October 2025. Again he presented with complaints of recurrent high grade fever with chills and complaints of abdominal distension. And during this last 9 months, he had got multiple admissions in CMC Vellore, where he was diagnosed as having where he was admitted with recurrent fever and sepsis, and they did ERCP 2 times, and then and the stent was removed in last April. And there they did imaging and liver biopsy, and they diagnosed him as Kerley disease with possible congenital hepatic fibrosis based on both imaging and liver biopsy. And during his last admission CMC Vellore, which was on September 2025, he had received almost 5 blood transfusions, and they did therapeutic paracentesis twice there. So he is having persistent sepsis and fever, and with elevated LFT there. So we thought of, with the presentation, possible diagnosis could be recurrent pyogenic cholangitis. And then later we reviewed his imaging. PET-CT and MRI was done in CMC Vellore, which was reviewed with our imaging, which was done in last admission. So there was considerable improvement in biliary dilatation, but the para-aortic lymph nodes which are present remained at this stable size of same 1.6 centimeter. So radiologists wanted to rule out IgG4 disease, so that we did IgG4, which came out to be normal. So the problem still remained, and was still getting fever, and there was persistent lymphadenopathy. And with this, we did investigation during this hospitalization, showed anemia with elevated inflammatory markers of ESR, and LFT was normal except for elevated alkaline phosphatase, and anemia, there was severe iron deficiency anemia was there. So peripheral smear showing microcytic hypochromic with increased reticulocyte count, and DCT was 2+. So we did our hematologist, we got a hematologist opinion, and they evaluated for anemia. In CMC Vellore, he underwent bone marrow biopsy, which showed normal cellular marrow with no any significant pathological abnormality. And other workup for anemia, hemoglobinopathies workup was done, which came to be negative. So we're still dealing with fever, anemia, and lymphadenopathy. So as a workup of lymphadenopathy with fever, anemia, we did other infections and autoimmune workup. So complement C3 was normal, complement C4 alone was low, and serum AC was normal to ruling out sarcoid disease. IGRA for TB it was negative, and for autoimmune workup ANA was negative. So even though all this workup, we still he remained undiagnosed. So with this, his last imaging was in July 2024-25. So again we wanted to do redo imaging to look what inside. So the CT abdomen showed similar mild hepatomegaly, diffuse bilobar intrahepatic biliacal dilatation, and CBD of 8.9 mm with mural thickening, possibly because of recurrent cholangitis also. And there was splenomegaly with dilated splenic vein and dilated portal vein. And in this also we noticed multiple lymph nodes were there. There was peripancreatic, pre-aortic, para-aortic, and mesenteric, and largest node was measuring around 3 cross 2 centimeter, which was para-aortic node. So with this background, we were thinking of infiltrative disorder. Could be anything, could be tuberculosis, could be lymphoma. So we want a definitive diagnosis. We attempted EUS in him. So we did EUS, tried for peripancreatic nodes, but due to node size was small compared to CT, and so biopsy was not feasible. We were not able to get biopsy through EUS. So we asked our interventional radiologist opinion to get a biopsy through ultrasound or CT guided biopsy, but due to blood vessels and due to the bowel, they were not able to find a safe site for the biopsy. So so at the time it became Jan. So his presentation October 2025, and it became Jan 2020 during evaluating this course because of his affordable issues. So we referred him for to surgical gastroenterology, took a lymph node biopsy diagnostic laparoscopy, but he was not willing for at that time. And our working diagnosis at that time was congenital hepatic fibrosis with portal hypertension and pyrexia of unknown origin, possibility of lymphoma or TB. So we discussed with the family members, as he was not willing for the procedure. We started him on empirical ATT, and he went back to his hometown and was soon followed. So he was good until April 2026. When he again came to a hospital with again similar episodes of high grade vomiting, upper abdominal, high grade fever, vomiting, and upper abdominal pain. And the investigations at that time showed similar anemia with elevated creatinine, ESR elevated, urine protein was 2+. And at that time imaging CT abdomen was done, which showed similar hepatosplenomegaly, IHBRD, and multiple enlarged nodes. And this time the node size were increasing compared to previous imaging. And there was periportal, peripancreatic, and para-aortic nodes was there. So this time we were able to convince him for diagnostic laparoscopy and lymph node biopsy. So followed by he underwent lymph node biopsy, and the node portal node was taken for biopsy. Along with it, wet biopsy of liver was done. So this was the histopathological images of this wet biopsy of liver. You can see the periportal fibrosis. These are the portal fibrosis, and this was in a jigsaw pattern. And this is the Mason trichome strain, which showing the collagen strain. So in biliary cirrhosis also there will be the similar finding of jigsaw pattern of fibrosis will be the portal fibrosis. So differentiating from this, in congenital hepatic fibrosis there will be angulated bile duct structures. So in this you can see there is an angulation of the bile duct. In biliary cirrhosis there will be straight bile duct structures will be there. So the features were consistent with congenital hepatic fibrosis. So proceeding with this, so then this is the histopathological images of the lymph node. So portal lymph node. So this was showing complete effacement architecture, and there was expansion of the interfollicular areas of the lymph nodes. So the residual follicles which were showed, there is a atrophy of the germinal centers was there, and there is increased sheets of plasma cells and many capillary blood vessels are there. So with this, the histopathological diagnosis was Castleman disease. So it's a diagnosis of Castleman disease of plasma cell type. So then we did investigations for this to prove this Castleman disease. So it is basically a disease of cytokine storm. So interleukin 6 was very much high with inflammatory marker, and the etiology workup for Castleman disease, HH8 was negative, with HTLV1 was also negative, and protein electrophoresis showing hypergammaglobulinemia. So with this all, we made a final diagnosis of Castleman disease of type of multicentric disease with congenital hepatic fibrosis with Caroli disease, probably Caroli syndrome. So we started him on treatment. He started on injection rituximab 500 milligram every 3 weeks once, along with steroids of 30 mg OD. And so he's due on, currently he was getting third dose of rituximab, and now the patient is doing good. The fever symptoms have subsided. So we have not done any repeat imaging yet now, so we are to do, but clinically patient is now doing good. So some points about Castleman disease, it's otherwise called as angiofollicular lymph node hyperplasia. So the classified, they usually classified as unicentric, multicentric and oligocentric. So depends upon the region of lymph nodes involved. So our patient is a multicentric Castleman disease, and it could be due to HHV8 associated, it can be due to idiopathic also. So idiopathic can be associated with Poem syndrome or Tafro syndrome. So Tafro syndrome is thrombocytopenia, anasarca, fever, renal dysfunction and organomegaly. And the main pathogenesis of this multicentric Castleman disease, it's a cytokine storm disorder, and the key interleukin is interleukin 6, which causes plasmacytosis, hypergammaglobulinemia, thrombocytosis, elevated all acute phase proteins, and activation of macrophages and T cells. And the main targeted therapy is interleukin 6 and interleukin 6 receptors. And the clinical features in Castleman disease, it can present with all features. It can present fever, hepatosplenomegaly, night sweats, weight loss, edema and ascites. And it's being a great mimicker of both tuberculosis and lymphoma. And lab findings, all the inflammatory markers being elevated, with hematology showing the decreased hemoglobin with elevated renal parameters, hyperalbuminemia and elevated all cytokines, interleukin 6 and VEGF. And rarely it can present autoimmune markers of positive DCT because of autoimmune condition. And our patient had almost all of these findings are positive in him. And treatment, it's because of cytokine storms, the treatment is mainly the immunotherapy. So drugs like cetuximab, which can inhibit interleukin macrophage dendritic cell, anakinra interleukin 1 receptor inhibitor, rituximab CD20 monoclonal antibody, which can inhibit the B cell, so thereby inhibiting the interleukin 6 production. Some of the direct receptors, the interleukin 6 receptor inhibitor like cetuximab can also be used. So in theory in multiple papers, cetuximab has been used in other centers where it has shown a good response against this Castleman disease. And tocilizumab can also be used, and in HHV8 infection we can use ganciclovir also associated with Castleman disease. Thank you. Sir, yes sir. In Castleman disease also ascites could be there, sir, because of infection. And in this patient we have congenital hepatic fibrosis also. Portal vein was dilated, and it's a high sac protein could be one of the cause.
So this congenital hepatic fibrosis usually it is a ductal plate malformation. It can be either 3 or 4 types. One is portal hypertensive type, which where often the children present with recurrent UJ bleed are often well tolerated without decompensation. Second is a cholangitis type where they present the recurrent cholangitis. Third is a mixed type, and fourth is atypical. This patient must be having a cholangitis type of your CHF. And usually being a pre-sinusoidal portal hypertension, ascites is very, very rare unless they go for your recurrent cholangitis and that time. Otherwise, I think the ascites in this patient must be part of your Castleman disease rather than CHF, because it is a pre-sinusoidal level of portal hypertension.
But how long did you treat the patient with TB medicines?
TB medicines, sir, 3 months, sir, till April, Jan to April, sir, 4 months, sir, last Jan. No, sir, in peritoneum nothing was there. In peritoneum nothing was there, sir. And instead multiple lymphadenopathy was there, and liver was also showing remodeling changes. IgG4 was normal, sir.
So she never had a cholangitis?
Yes, sir, initial presentation was cholangitis, sir.
Can you tell me about the incidence of Castleman's disease in India? Do you have any idea?
Sir, I reviewed the articles, but it was changing in.
What about international journals?
International journals, they showed 5 in 1 lakh population, sir.
No, that's rather unusual. It should be still more lower. I have not seen in my 55 years of experience of Castleman's disease. I will not think of Castleman's disease in this in our country. It's very rare presentation, but rarer things do occur.
Sir, Tafro syndrome, yes, sir. Yes, sir.
Severe form of Castleman.
Yes, it's one.
Now, even though the patient is having this ascites and other presentation,
Yes.
why not you should Tafro rather than
The
selling only
Tafro syndrome, there was thrombocytopenia was also there, but our patient did not have thrombocytopenia, sir. His platelet load was around 2 lakhs, 1.5 to 2 lakhs was maintained. It doesn't fit into that. Thank you.
So up next we have Dr. Srinandini KR from Kilpak Medical College with the presentation topic of acute small bowel obstruction beyond the obvious.
Good evening, everyone. I am Dr. Srinandini from Kilpak Medical College. I am going to present about a topic of cases of acute small bowel obstruction beyond the obvious. Before going to the topic, I thank my HOD madam for giving this opportunity. A 44-year-old female patient presented to ER with a history of abdominal pain, which was initially intermittent and relieved on its own for 4 days, and it becomes continuous for the 2 days, associated with vomiting and not and associated with history of passing knots, stools, and flatus for 1 day. No history of similar complaints in the past, no history of surgeries in the past, and no history of tuberculosis, bronchial asthma, and patient has no history of drug allergy or any food allergy. On examination, patient vitals were stable. Abdomen examination showed abdominal distension with no guarding and rigidity, but bowel sounds were absent. Routine investigation revealed normal report except for a elevated eosinophil count of 8.4%. Imaging showed a short segment thickening, which is noted in the mid ileum with a maximum thickness of 10.1 millimeter with adjacent predominant vasa recta and fat strandings. Minimal free fluid noted in the pelvis. Jejunal and proximal ileal loops appears dilated with a small bowel feces sign with a maximum diameter of 3.2 centimeter. Jejunal and ileal loops appears adherent to each other. So this is a edematous small bowel with the luminal narrowing. The patient underwent exploratory laparotomy, and the stricture was intraoperatively. Stricture was noted in the distal ileum around 100 centimeter from the IC junction. Fluid noted in the pelvis. Resection of the affected ileal segment done. End-to-end anastomosis was performed, and post-operative course of the patient was unremarkable. The next case, 47 years old male patient presented to ER with history of abdomen pain for 1 day, and similarly no history of any similar complaints in the past, and no past history of surgery, and no history of TB or allergy or bronchial asthma. This patient also had a abdominal distension with absent bowel sounds. Again, the investigation showed elevated eosinophil count of 9.2. Apart from that, all other reports were normal. And the imaging showed dilated bowel loops with ileal and jejunal loops appears prominent with maximum luminal diameter of 3.1 centimeter, showing air fluid levels with transition point at the distal ileum. Small bowel feces sign, and bowel wall shows normal enhancement with minimal free fluid noted in the pelvis. So this is a dilated multiple air fluid levels with the transition point and the small bowel feces sign. So this patient also underwent exploratory laparotomy, which intraoperatively stricture noted in the distal ileum around 60 centimeter from the IC junction. Proximal loop distended, distal loops were collapsed. Redness noted from mid jejunum to the left stricture. IC valve appears normal. Multiple mesentery contusions seen at 100 centimeter from the IC junction. The affected part was resected, and the double barrel ileostomy was performed. Post-operative course was unremarkable. Both patients are discharged, and they are referred to MG department with a histopathology report, which is suggestive of eosinophilic enteritis. So this is the histopathology report of the first patient showed the lining ileal mucosa with a transmural dense sheet of infiltration by eosinophils along with scattered mast cells, few histiocytes, and focal area exhibit mucosal edema with congested blood vessels. So, and they are reported as a eosinophilic enteritis. Second patient histopathology reports it also shows transmural inflammatory infiltrates composed sheets of eosinophils with a few lymphocytes. Submucosa and serosa shows mucosal edema and congestion, and reported as eosinophilic enteritis. So we proceeded with the further since patient has come to us only after surgery with the histopathological report, we wanted to rule out the other causes for eosinophilic and secondary causes of eosinophilic enteritis. So we proceeded with certain some investigations, and which showed we did absolute eosinophil count, which is elevated than normal, but it does not it is not more than 1500 to meet the criteria for hypereosinophilic syndrome. And we did fecal calprotectin to rule out active inflammation in both patients. In first patient it is less than 10 milligram per kilogram, and in second patient it is 54.7, and stool ova cysts were negative, not detected. We did a upper GI endoscopy and we did a mucosal biopsy, and endoscopy was normal, and the biopsy report showed in duodenum it is a chronic duodenitis with a few scattered eosinophils, antrum H. pylori induced chronic gastritis, and in esophagus normal esophageal lining. In another patient it showed a chronic ileitis with scattered eosinophil, but it does not fulfill the criteria for eosinophilic enteritis. We also did a colonoscopy. In the colonoscopy report, colonoscopy for was also normal, with the biopsy report not suggestive of eosinophilic colitis. And we did a CT enterography for both patients, which was found to be normal with normal mucosal enhancement. So both patients are asymptomatic, asymptomatic following surgery. So both patients are under follow-up. We have not started any treatment for both patients. So eosinophilic gastrointestinal disorders, these are a rare chronic inflammatory disorders of the gastrointestinal tract. It is divided into eosinophilic esophagitis and non-eosinophilic non-esophageal eosinophilic gastrointestinal disorders. It can affect any part of the GI tract, from esophagus to colon. The most common part affected is eosinophilic esophagitis, and it is most studies are on only available for eosinophilic esophagitis when compared to the other segments. Eosinophilic esophagitis accounts for 89% of eosinophilic gastrointestinal disorders, whereas eosinophilic enteritis is approximately 5 to 8% and colitis is 3%. The common presentation for eosinophilic esophagitis is a dysphagia, food bolus impaction, chest pain, feeding difficulty when it occurs in children. And for enteritis, it can present as abdominal pain, diarrhea, malabsorption, weight loss, obstruction, ascites. For large bowel, it can present as abdominal pain, diarrhea, hematochezia, or weight loss. For a diagnosis, the important criteria for diagnosis is mainly based on histopathological examination, based on the number of eosinophil count per high power field. For each segment it varies. For esophagus it should be more than 15 eosinophils per high power field. For stomach, it should be stomach and small intestine, it should be more than or equal to 30 eosinophil, 30 cells. And for colon, for the right colon, it should be cecum and ascending colon more than 100. And for the transverse and descending colon, it should be more than 50 cells per high power field. Coming to eosinophilic enteritis, it is characterized by a presence of intense eosinophilic infiltrate on the histopathological examination of the intestinal mucosa. The presentation varies based on the layer which is involved. It can be mucosal, muscular, or serosal. The mucosal involvement is the most common involvement, which accounts for 57 to 100%, and it's the most common presentation, clinical presentation. And the muscular presentation is 30 to 70%, and serosal presentation is 4.5 to 13%. Mucosal presentation, the typical symptoms are abdominal pain, diarrhea, nausea, vomiting, malabsorption. weight loss, anemia, protein losing enteropathy, or GI bleeding. For a muscular part, it can be bowel wall thickening, intestinal obstruction, gastric outlet obstruction, small bowel obstruction, intussusception, vomiting, abdominal pain. For serosal involvement, predominantly abdominal distension due to ascites. Coming to the natural history, only few studies are available on eosinophilic enteritis. A study from France showed that observed the patient with eosinophilic enteritis for 15 years and showed there are 3 patterns can be possible. It can be a single flare followed by no recurrence, or it can be multiple recurrent flares with remission, or it can be a chronic disease without any remission. And the single flare with no recurrence accounts for 44%, recurrent episodes with remission 36%, and chronic disease accounts for 21%. The disease course vary. In case of childhood onset, the course is more likely to be a continuous disease. For esophageal involvement also more likely to be a progressive disease. For diagnosis, it requires 3 points, mainly presence of GI symptoms with histopathological findings of eosinophilic infiltration of the intestine and exclusion of secondary causes of intestinal eosinophilia. The secondary causes of our eosinophilia may be due to hypereosinophilic syndrome or any parasitic gut infections, drug and toxic substances like gold therapy, antibiotics, NSAIDs, inflammatory bowel diseases, Crohn's disease, ulcerative colitis, celiac disease, vasculitis, polyarthritis nodosa, eosinophilic granulomatosis with polyangiitis, autoimmune diseases like scleroderma and neoplasm. So, the treatment is mainly steroids, immunosuppressants. Other supportive treatments includes mast cell stabilizers like sodium chromoglycate, antihistaminics like ketotifen, and leukotriene antagonist Montelukast can also be tried. In case of eosinophilic esophagitis, PPA was found to be useful. In case of refractory cases, biologicals can also be tried. Since we have operated the patient and we have removed the affected segment, and after surgery the evaluation showed there is no active inflammation, we have doubt about starting treatment because the treatment is mainly based on immunosuppression, and the duration of treatment also we don't know. So we reviewed the literature, and we found that the medical therapy after surgical resection, there is no proper consistent guidelines for eosinophilic enteritis. According to literature, approximately 40% of eosinophilic gastroenteritis patients eventually require surgery, and roughly 50% of these recur despite excision of the affected segment. So resection alone is not curative, and steroid sparing adjuvants like Montelukast, mast cell stabilizers can also be tried instead of steroids in selected cases. And some studies also showed that steroids were withheld after resection of the affected segment, and patient were on a follow-up for the disease recurrence. And follow-up, the relapse is common even after surgical resection. 33% there is a recurrence, and 60% 60% in cases when patient is on steroids at the diagnosis, and 45% following steroid withdrawal. There is a one case report similar to our case, reported in gastroenterology oncology surgery article. In this, the 72-year-old female patient presented with acute small bowel obstruction, and the patient was underwent emergency laparotomy with resection of the affected segment, and this patient was not started on any treatment, and this patient was on follow-up for 1 year, and there was no recurrence of disease. So, eosinophilic enteritis is a rare disease, and presenting a surgical emergency is less common. There is no consensus guidelines for management of eosinophilic enteritis regarding treatment and follow-up, and even after resection also we don't know whether we have to continue the treatment or we have to keep the patient on follow-up. Thank you.
So we have treated the disease, obstruction part being treated. What about the primary event? So what are you going to do? So you have done a biopsy, post-operative histopathology sample has been done. Is there any role of steroids at this point of juncture?
Sir, actually, we have done CT enterography after resection, sir, after 6 weeks of surgery. And there is no evidence for any mucosal involvement or thickening of the bowel wall, and the fecal calprotectin also within normal limit. And since the treatment is mainly based on immunosuppression, we don't know the duration of treatment required for the patient. We are now keeping the patient on follow-up, sir, without any treatment. But we are not sure about the recurrence part. We are also having doubt in whether to start treatment or wait, or with low dose.
Immunosuppression means you're talking about biologicals, or you're talking about this steroids alone?
Steroids and with steroids and immunosuppressants. Mainly steroids, sir.
Was there any eosinophilic abscess in the biopsy report?
No, sir. No,
Did
sir.
they mention about the eosinophil count?
Yes, sir. They have mentioned about the eosinophil count. It's more than 60 cells, sir.
More than 60?
Yes, sir.
Okay. Thank you.
But usually eosinophilic events will be a diagnosis exclusion. Now, even then, but we are not be looking for all the major possible workups. Now, even celiac disease could be a coexisting presentation, whether we have done all the celiac workups or
Yes,
Crohn's
sir.
workup. See, it's still a challenging task to diagnose the entire event now. So this kind of patients, even though acute small bowel obstruction been improved for the time being, serial monitoring is absolutely indicated.
See, there has been only one stricture. There has been only one stricture, and all your investigations do not prove that any other place there is eosinophil which is higher. So basically, I don't think it is eosinophilic esophagitis, because the stricture per se can cause eosinophilic infiltration.
Yes, sir.
So the other places, none other places involved, and you are claiming it to be eosinophilic enteritis, I would take it with a pinch of salt.
No, yes, you can take it with a pinch of salt, but we have discussed with the pathologist, even the gross specimen, she was definitely, it was not a Crohn's. She told there was no creeping fat on the mesenteric side, and histopathology, you are having the full thickness specimen and an eosinophilic dense infiltrate. So
No,
the
madam,
second
that
case,
is, I'm not telling it is IBD.
So then
but I am not
it was a
happy to accept that it is eosinophilic enteritis. I do not know what is the other causes, but because an obstruction in a sink per se itself can cause eosinophilic infiltration is my opinion. That's all.
no, it was a,
Nothing we are going to do. That is a different issue. But branding it as eosinophilic enteritis, I don't know. Will you accept that? In one place of the entire small bowel, the eosinophils are there. How is it even pathologically possible? Will you accept it? It is a disease, it is a systemic disease.
Ascites. To make a diagnosis of eosinophilic etiology for ascites was so difficult. Now, why is it the serosa is involved?
It is the serosa, the
No.
entire serosa is involved.
What I'm
Here
trying-
only one part of the small intestine is involved.
I would like to say what I'd like. Yeah, I'll tell you only one thing that Dr. Thambaya said. If you unravel the etiology of systemic lupus erythematosus, it's a systemic disease. 90% of the blood flow goes to the skin and other things. But why do you have islands of skin involved? This is exactly what Dr. Thambaya said. Why is islands of skin involved in a systemic disease like systemic lupus erythematosus? So that way, I think the eosinophilia affecting a segment could be accepted.
You don't do plain X-ray abdomen, is it?
Yes, sir, we do, sir.
What is the plain X-ray abdomen? You have not projected it?
Sir, it showed a dilated.
Straight away, without CT, you don't want a diagnosis.
No, sir, this patient referred to us from surgery.
No,
sir.
I'm asking you.
Yes, sir,
like
I
that
should
you
have
are coming from medical
yes, sir.
college.
Yes, sir.
And you are saying you are not done, said anything about
Yes, sir.
plain X abdomen, right? Then it was an emergency laparoscopy. It's not a pre-operative diagnosis of eosinophilic enteritis. It's a pathological diagnosis after the resection. So clinically, you cannot make out eosinophilic enteritis,
Yes,
right?
sir, yes, sir.
It's only pathology. You can get surprises in pathology many times. Don't worry, it may be still be eosinophilic enteritis, right? Without, when do you call it enteritis? There should be diarrhea. There's no diarrhea. No diarrhea. None of the patients had diarrhea. No, you are saying you do not know what is the biopsy report. Is it for the full muscle layer or mucosal layer? No, full thickness biopsy. I say it's resected specimen. But to call it enteritis is also another question mark. A rare case of intestinal obstruction, finally histopathologically proven as eosinophilic disease. Sorry, doctor, it was a nice presentation.
Thank you.
You did well.
So the last topic for this session will be done by Dr. Satvika Reddy Attipalli from SRM Medical College Hospital and Research Center on topic Journal Scan, review of recent publication from India in the field of liver disorders.
Okay. Good evening, respected teachers and my dear colleagues. I'm Dr. Satvika, first year medical gastro postgraduate from SRM Hospital, Chennai. So I'm going to be doing an article review of the past 3 months publications from the liver disorders from India. So the outline is I'll be presenting 2 articles from hepatitis A, 1 from mast cell, 2 from ACLF and 2 from cirrhosis in the topic of cirrhosis. So the first article, it was done by Epensor's team in CMC Vellore. It's exploring the role of therapeutic plasma exchange for hepatitis A related acute liver failure. It's a multi-center cohort study. It was published in the journal Indian Journal of Gastroenterology on 3rd April 2026. So the aim of the study was to see if PLEX was useful in ALF secondary to hepatitis A. So it was a retrospective multi-center cohort study, and they took patients who were confirmed hepatitis A and the diagnostic criteria was positive anti-IgM HAV antibody, diagnosis of acute liver failure of any degree of hepatic encephalopathy plus coagulopathy within 26 weeks of jaundice onset in the absence of pre-existing chronic liver disease, and consecutive patients were treated with PLEX or standard medical therapy at the participating centers. Exclusion criteria were patients who underwent liver transplantation or patients with a pre-existing chronic liver disease. So the intervention that they had done was PLEX. They used 2 high volume and standard volume PLEX. High volume was 2500, that was standard volume, sorry. Low volume was 1500 ml. And the number of sessions were determined by the physicians in the centers. It was not protocol based, and they also use of steroids also was done for some patients, and that was also the individual clinician's decision. It was not a prefixed protocol that they used in the study. So out of 234 patients, they categorized 84 patients in the PLEX group and 150 patients in standard medical therapy group, and they compared all the other scores as well. SOFA MELD, hepatitis A acute liver failure score, and most patients in SMT group required mechanical ventilator and 75 patients were on inotrope supports. Usually PLEX is not recommended for patients on inotrope supports, but they also involve patients who were on inotrope support in this study though. So overall they found that there was no significant difference in patients who underwent PLEX versus standard medical therapy in hepatitis A related acute liver failure. But there was also a subgroup analysis that was done in this study, which were patients who were not on inotrope support. Among those, there was a small difference that patients who were not on inotrope support and early on started with PLEX in hepatitis A related acute liver failure had a benefit. But that also, after they matched the other variables like mechanical ventilator and all, it was not significant enough. So on univariate analysis of the subgroup of hemodynamically stable patients not on inotrope support, PLEX significantly improved survival with a p-value of 0.02, but on multivariate analysis, it failed to show any survival benefits. So the limitation of the study was it was a retrospective study, and there's lack of standard protocol was number of sessions used, the steroid usage in PLEX, and this study looked at in-hospital outcomes only. We don't know what happened to the patients post-discharge as well. So ultimately the conclusion of the study is saying that PLEX per se in patients with acute liver failure secondary to hepatitis A has benefit only if it is for patients who are not on inotrope supports and started early on, but that also there is a small window of opportunity and we need further studies to prove that. So the next study is clinical profile and prognostic predictors in hepatitis A virus induced acute liver failure. So this was published in Journal of Clinical and Experimental Hepatology in 2026 June, and the place of study was Mahatma Gandhi Medical College, Jaipur. So in this study they tried to evaluate, so there are a lot of scores that are available to predict mortality in acute liver failure, but none of them are etiology specific. So to see for patients with hepatitis A, which score is most accurate to predict mortality in hepatitis A related acute liver failure, they conducted the study, and also what were the other predictors like ammonia, INR. They wanted to see which of it was most significant in predicting mortality in acute liver failure, hepatitis A induced. So objectives were compare clinical and laboratory parameters between survivors and non-survivors, perform univariate and multivariate logistic regression to identify independent predictors of mortality, assess discriminatory accuracy of prognostic scoring system, and evaluate combined score performance to improve diagnostic accuracy. So this was a retrospective observational study, and the study population was people more than 14 years of age, serologically confirmed hepatitis A by IgM antibody, and ALF was defined as hepatic encephalopathy plus jaundice plus INR more than 1.5 within 4 weeks of symptom onset with no pre-existing liver disease. So the sample size here were 79 HIV ALF patients. Among these 79 patients, 20 patients had died and 54 patients survived, and 5 patients went for liver transplant. So these were the scores that they compared: MELD score, acute hepatitis A associated acute liver failure score, King's College criteria, acute liver failure study group index, acute liver failure early dynamic model. So total acute liver failure admissions in that hospital were 105, and the age of the patients were an average 20, male predominant. Hyperacute liver failure was 61%. HE graded presentation was 2 in 9 patients, 3 in 37 patients, and 4 in 33 patients. 88.6 required mechanical ventilator and 44 required CRRT. Outcomes recovered with medical management were 54, liver transplant was 5, and 20 died, and cause of death was predominantly sepsis, bleeding, and brainstem herniation in 4. So results, predictors of mortality, these were the clinically significant, statistically significant predictors of mortality in hepatitis A acute liver failure. Higher MELD score, longer prior hospitalization, elevated INR, elevated lactate, elevated ammonia, and higher WBC count. And among all these, lactate and MELD score were the 2 most important predictors in acute liver failure in hepatitis A. So the limitations, it's a single center retrospective study. Findings may not be generalizable to other populations or healthcare settings. A small sample size. Liver transplant recipients were censored as a competing event which may affect the outcome analysis, and complementary and alternative medication was used in 15.2% of the patients, potential confounder. So the conclusion of the study is serum lactate is a strong early predictor of mortality. MELD outperforms the currently available prognostic tools, and the classic King's College criteria and recently proposed acute liver failure early dynamic score shows important limitations in this setting. These findings underscore the necessity for improving etiology specific prognostic models tailored to the unique clinical course of hepatitis A associated acute liver failure in young adults. So the next article is MASL related. This article compared in patients with MASL who were non-obese, saroglitazole versus standard lifestyle modification. So this was a prospective randomized controlled trial done in post-JIPMER and it was published in Indian Journal of Medical Research. So the aim of the study is to evaluate the efficacy and safety of saroglitazole 4 mg per day in non-obese MASL and NAFL patients when added to lifestyle modification compared with lifestyle modifications alone. Methodology was randomized controlled trial. The population were more than 18 years, non-obese, non-obese BMI being less than 25 kgs per meter square, and ALT value of more than 50 without cirrhosis or any other cause of liver disease. Totally analyzed patients, and group A were 33 in the saroglitazar group, and group B were 33 who underwent the standard lifestyle and diet changes. So the outcome is, amongst the primary was control attenuation parameter, which they measured via fibroscan. They did not do a biopsy or any or an MRI as well. They just measured it using elastography. And secondary outcomes were BMI, waist circumference, HOMA-IR, HbA1c, lipid profile, ALT, FAST score, hepatic steatosis index, liver stiffness, APRI, FIB4 and other adverse events. So they followed these patients up for 6 months, and at 3 months also they did a baseline laboratory test. So the results of this study was patients who received saroglitazar 4 mg daily improved in 3 things. One was insulin resistance, triglycerides and ALT levels, but there was no significant difference in liver stiffness measurement, FIB4, APRI, FAST score or hepatic steatosis index. No serious adverse events were reported as well. So the limitations of this study, it's a small group open label design, short follow-up only for 6 months, because usually it takes longer for steatosis and fibrosis to change, and no histology or MRI for detecting small incremental steatotic changes. And HOMA-IR was underpowered, improved significantly, but it was not a secondary endpoint at the starting of the study. And low baseline fibrosis burden, low LSM values and limited metabolic comorbidities may restrict generalizability and availability to detect fibrosis changes. Conclusion, a non-obese mast cell NAFLD adding saroglitazar to lifestyle modifications for 6 months improved metabolic parameters like insulin resistance, triglycerides and ALT, but did not change much in CAP values or LSM values. So it does not provide any additional benefit over lifestyle modification alone in reducing hepatic steatosis or improving non-invasive fibrosis markers. So the next study is on ACLF. So this is consensus versus outcome-based definition on acute and chronic liver failure. So this study aimed to see if the currently used Kyoto consensus that was given in 2025 World Gastroenterology is good enough to categorize all patients as ACLF, and is it good enough to see if the mortality at 28 days and 90 days was predicted well by it. So this was actually a study that was a multi-center study. It also included centers from China as well. So one score that the Indian cohort and Chinese cohort were around 2000 people, and they applied both the scores on each of the cohort and saw the validity. So the aim is to compare the clinical validity of the recent proposed 2025 consensus ACLF framework with the outcome calibrated A-Tango classification across 2 independent multinational cohorts. A-Tango was another definition that was given by the Chinese, and to see if it adequately is able to pick up patients with ACLF among patients with cirrhosis. So to compare differences in ACLF case capture between 2 frameworks, to assess clinical characteristics and short-term outcomes, 28-day and 90-day mortality of patients identified by each framework, to determine whether patients classified as non-ACLF by the consensus definition could be further risk stratified using A-Tango, to evaluate sensitivity, specificity and net reclassification improvement of each framework. So the TIH cohort was from the Indian cohort basically, it's a multi-center PAGH, Chandigarh, AIG, AIMS, multiple centers, and it was 2,398 patients were enrolled, and Catch Life was a Chinese cohort where 2,568 patients were enrolled. So inclusion criteria was age more than 18, non-elective hospitalization with acute decompensation of cirrhosis. TIH cohort, patients from PJ Chandigarh and Amrita Kochi. Catch Life, patients enrolled from 14 centers across China. So A-Tango organ failure was bilirubin more than 20 mg. Either one of the 4 was sufficient to diagnose, either liver or kidney or brain or coagulation. Circulatory and respiratory were not taken into account. So single liver, kidney, coagulation or respiratory was sufficient to diagnose ACLF, whereas isolated brain or circulatory failure required an additional organ dysfunction to meet the ACLF threshold. And the consensus guidelines is liver failure with bilirubin more than 7.5 plus INR more than 1.5 plus more than one extrahepatic organ involvement with West Haven criteria for encephalopathy more than 2, AKI stage 2 or dialysis, circulatory MAP less than 65 mmHg or vasopressors, and respiratory PaO2 FiO2 ratio less than 300. So the primary outcomes of this study was the consensus guidelines, the 2025 Kyoto consensus guidelines, according to the study, underestimated the patients who had ACLF. So in the A Tango classified 1,899 of the 2,398 patients as having ACLF, whereas the consensus framework classified 1,014 patients having ACLF. That is 79% of patients were categorized as ACLF according to A Tango, and 42.3 were categorized as ACLF. And this was in the Indian cohort, and Catch Life cohort, out of the 2,568 patients, the Catch Life criteria, the Chinese criteria picked 807 people as having ACLF, but the consensus guidelines picked only 150 patients as having ACLF. And actually when compared, the hazard ratio also was higher. So they're trying to say that consensus 2025 guidelines is very specific, but it is not very sensitive. But the A Tango score is more sensitive. It picks a larger group of people and identifies them as ACLF. So the conclusion of the study is they're trying to say that not just APASL or ASL or ACLF, it is important to bring in more classifications and integrate them to put a proper definition for ACLF to pick patients early. So incomplete census operationalization, immune and gastrointestinal, so the limitations are two other organ failures which are immune and gastrointestinal failure domains were excluded. These two are part of the 2025 criteria consensus, and baseline creat approximation was not done. Retrospective component, no liver transplant in the Indian group was mentioned, and cross-regional heterogeneity, Indians and Chinese population. So the next study is a score, basically platelets, liver stiffness measurement and spleen stiffness measurement based modality to identify patients who have acute or chronic liver failure if they need endoscopy, to see if how many of the patients actually need an endoscopy. So they developed a score. It was a non-interventional score. So basically to develop and validate a non-invasive prediction model using platelet count, liver stiffness measurement and spleen stiffness measurement for identifying esophageal varices needing treatment in patients with acute and chronic liver failure, thereby reducing unnecessary endoscopies. So this was done in ILBS based on APASL criteria. ACLF was categorized. LSM and SSM were measured. EGD was performed within 7 days of the LSM SSM measurement to create the score, and VNT is varices needing treatment were defined as having small varices with a red color sign or large varices were considered as VNT. So why it was more important to do this in ACLF patients, because ACLF being a pro-inflammatory disease, it has higher chance of bleeding when compared to a person with compensated chronic liver disease. So patient characteristic, total screen with 339, analyzed with 216, 95% were men, and MELD score of 25.5 average, etiology alcohol being the predominant etiology. So the three key things that they compared were platelet count, LSM, SSM. So they found that platelets of less than 1 lakh was more significant, which is already known, but LSM of more than 71 is more significant, and SSM of 76 is also very significant. These are very high scores. And the score description, so the score ultimate value was 0.0168. If the score was more than 0.0168, then it's a high risk and the patient has to undergo an endoscopy. If the score is less than 0.0168, then the patient is at a lower risk and it can be safely deferred. So the results were 206 patients were analyzed. The model had an area under the curve of 0.842, sensitivity 95, specificity 66, positive predictive value of 72, negative predictive value of 93, accuracy of 80%. So this score basically helped to pick patients Even in resource limited settings, if we have to refer the patient for endoscopy, or it can be deferred. But limitations were the single center cross-sectional design. It was conducted at ILBS again. No longitudinal follow-up was done, and the model predicts VNT at a single time point. Its utility for serial monitoring is unknown, and there is no validation cohort. They basically did something called bootstrap analysis, where they tested it on the subjects who were used to develop the score itself. Take-home points: 48.2% of ACLF patients had varices needing treatment. Spleen stiffness, liver stiffness, and platelets were the only independent predictors. And using a cutoff of 0.0168, the model achieved highest sensitivity specificity and can be safely avoided in 34.3%. And the model remained accurate for bootstrap internal validation and performed well in both alcohol and non-alcohol related ACLF. The next article is on point of care ultrasound guided pragmatic fluid and albumin resuscitation and hemodynamic monitoring in cirrhosis and septic shock. So this study was done in JIPMER and AIG Hyderabad and Apollo Kolkata. So they used the patients from PGH Chandigarh to develop the protocol, and they later tested it on AIG Hyderabad and Apollo. So what they did was, they to evaluate clinical outcomes of two POCUS guided pragmatic fluid resuscitation strategies, balanced salt solution plus 20% albumin versus balanced salt solution alone in patients with cirrhosis and septic shock, and to assess the impact of cirrhotic cardiomyopathy on outcomes. So to compare 28-day, 90-day all-cause mortality between the two fluid resuscitation strategies, to assess the incidence of sepsis-related circulatory failure in each group, to evaluate the impact of CCM and circulatory failure, to determine predictive role of dynamic POCUS parameters, to assess adverse events, and to validate findings from the discovery cohort and a multi-center validation cohort. So it was a prospective interventional study with propensity matched discovery cohort and multi-center validation cohort. So they included patients with cirrhosis of any etiology with presumed sepsis-induced hypotension, sepsis defined as suspected or confirmed infection with a SOFA score of more than 2, fluid responsive septic shock. So exclusion criteria: all patients who had CKD, CAD, a known left ventricular heart failure, hepatocellular carcinoma were all excluded. So POCUS was performed at the time of admission: 6th hourly, 24th hourly, 24 hours, 48 hours and 72 hours, and whenever required. And POCUS measured IVC diameter, IVC collapsibility index, ejection fraction, cardiac index, stroke volume, lung ultrasound score. Basically they saw two things in ultrasound, lung ultrasound. If the patient was not having any pulmonary overload, there's A line, so they called it as lung A line. And if the patient had pulmonary edema, curly B line, so they were calling it B, lung ultrasound score B. So resuscitation target of MAP more than 65 mm Hg, and IVC collapsibility, IVC diameter is 1.8 to 2 centimeter. IVC collapsibility index was 20 to 30% and lactate clearance. So results, they saw that there was not much difference between patients who received albumin and balanced salt solution. It's just that giving albumin to the patient significantly reduced the need for giving more of balanced salt solution to resuscitate them. This is just to improve the hypotension. And the use of POCUS helped majorly to prevent putting the patient in over volume state and developing pulmonary edema. So these were the major findings of this study. Conclusion: POCUS guided hemodynamic monitoring in cirrhosis with septic shock is feasible and effective in achieving mortality rates of 34 to 40%, substantially lower than the historical cohorts of 58 to 62%. The addition of 20% albumin to balanced salt solution does not confer a survival benefit at 90 days compared to balanced salt solution alone. 20% albumin significantly reduces the total crystalloid volume infused with low rates of pulmonary edema. Cirrhotic cardiomyopathy is an independent predictor of circulatory failure and mortality irrespective of fluid strategy, baseline MAP or MELD sodium. Hemodynamic profile at 6 hourly, hypovolemic septic shock versus circulatory failure, not fluid choice, determines the prognosis.
Dr. Sathika, it's still more, how many channels, sir?
Just one more, sir. I think last.
It's already late.
I'm sorry, sir. This is the last one. I can just rush through this. So this so this study, safety and efficacy of transjugular intrahepatic portosystemic shunt in patients with liver cirrhosis and hepatorenal syndrome, non-acute kidney injury and refractory ascites, the retrospective analysis. So basically, they took patients who had NAKI that was developed, that was defined as creatinine value of more than 1, but for more than a month. So it was not HRS-AKI basically. So they randomized patients, 35 as TIPS group and 35 were matched controls. This was a retrospective study. So, and they also made sure that the creatinine values in these patients were only 1.5 to 2, and the intervention was TIPS. And the result of the study was that doing TIPS in these patients actually helped reduce the creatinine, reduce the ascites, the number of large volume paracentesis that were done also were significantly reduced. Biochemically, it improved urinary sodium, serum sodium improved, serum albumin improved, plasma renin activity significantly decreased, and MELD score also remained stable. And so adverse effects, hepatic encephalopathy in the standard medical therapy versus TIPS group was not statistically significant. So they're saying that doing TIPS might help, even though hepatic encephalopathy is a side effect. It was not statistically significant in this study that they had done. So the conclusion of this study is doing TIPS in patients who are HRS, NAKI and who cannot go for liver transplant or already developed HCC might help to have a better prognosis and required less number of large volume paracentesis. So conclusion, TIPS decrease the activity of renin, angiotensin, aldosterone system, leading to improved renal function, serum sodium and ascites, along with a lower rate of AKI compared to control group, without a significant increase in overt hepatic encephalopathy and 6 months mortality. Therefore, TIPS can be an option for refractory intractable ascites with NAKI and among the patients who do not have liver transplant option and a creatinine of more than 1.5 but less than 2 mg per dl. Thank you.
So we'll discuss later in view of want of time. Thank you. So up next we'll have Honorable Secretary Dr. Perumanagam sir's
Dr. Anirudh, Dr. Praveen, Dr. Sri Nandini, Dr. Satvika Reddy, thank you, sir. We'll move on to we'll make a short secretary report. I'll congratulate Dr. T.S. Chandrasekhar, who's been elected as the ACG India Governor again. I think this is the second time he's getting elected for the same. And also it brings us great pleasure that Tamil Nadu ISG Postgraduate Travel Grant, which has been introduced the last couple of years, has brought out really good interest among the postgraduates. There are 2 grant awards every year, and this time around Dr. Sanup Kumar Shireen Sabu from GEM had presented his work at APASL 2026 at Singapore, and it's nice that in your second or third year you're able to present your work in an international forum. I congratulate Dr. Sanup, and I hope he brings on and brings it out into a paper as a manuscript and publishes it. And I'll request Sir Dr. Raghuram Sir, Senior Most Gastroenterologist here, and Dr. Vinod also to join to present this check for 1 lakh rupees to Dr. Sanup Kumar Sahu. Thank you, sir. Thank you, sir. Also, I congratulate Dr. Monica, a postgraduate from ICH, who has gone to present in the European Society of Pediatric Gastroenterology, Hepatology and Nutrition at France, and she won the Young Investigator Award in June 2026 for her work, and I hope She also again applies for the TNISG postgraduate travel grant this time around. So congratulations, you could bring it list. Forthcoming meetings, most important thing is that Tamil Nadu ISG midterm conference is at Madurai. It has been postponed by 1 week because it was initially planned for 17th and 18th. Please mark your dates. It's on 24th and 25th of October. The earlier dates were coming in the midst of Ayudha Puja, so I think they've planned to change it by 1 week, postpone it by 1 week. The annual TNISG conference will be held at Chennai, that is on 30th and 31st of Jan. On 29th, we plan to have a postgraduate session also. The Indocon will be from 28th to 30th of August 2026, and the WCOG conference will be on 30th September to 3rd October 2026. And also, so those all the members are requested to register. Last week also we had an online meeting from the Central Committee to request and to encourage all state chapter participants to register early for the WCOG conference. They are expecting close to about 3,000 participants, at least 3,000 to 3,500 participants. It has been overwhelming response. Close to about 800 to 900 abstracts have been submitted, which is much higher than what is usually here from all across the world. So they are really expecting a very good academic experience. So please do register and participate in the same. And the same setting, I would also again reconfirm that the next year's ISG conference will be held in Chennai. It's been awarded to Chennai, so we'll be working on the dates and the center also, and will be involving majority of the people who've been regular with our meetings to be part of the committees as well. So I think work is on that, so we'll be updating you on that as well. So the Tamil Nadu ISG research project, the HCC epidemiology data, it's in the data analysis phase, and shortly they will be bringing out an abstract as well. An abstract has been submitted in WCOG with this data, whatever has been there. The GERD study, the study design has been finalized. Dr. Illavarsi is not here, otherwise we would have requested her to give an update. And shortly in the next couple of months, after getting the Institutional Ethics Committee, the work on it will also start. So I request all the academic trainees and postgraduates to kindly register and become members, student members of the Tamil Nadu ISG, and also to become members of the national body, because to become participate in the National Society meetings, you have to be a member of the ISG as well. Please do scan the QR code that is in your desk so that we can update and possibly will get some points for our monthly meetings as well. And now over to the CME part. I request Dr. Thai Manavan and Dr. Sumati Madam to please come over to the dais and conduct the proceedings, please.
Good evening, and thanks for the opportunity. Today we are discussing a very important topic on inflammatory bowel disease that is now gaining importance in this part of the world. When we were students, we hardly saw any patients with Crohn's or ulcerative colitis. The number of cases of bleeding were due to specific causes. But today, the entire shift has occurred, and the number of cases that the West sees and what we see in Asia is probably the same. And to discuss one very important topic of anemia in inflammatory bowel disease, which is multifactorial, we have Dr. Hariharan from Apollo Hospitals to tell us the etiology, the diagnosis and the management of anemia in inflammatory bowel disease. Over to Dr. Hariharan.
My teachers and my friends, respected chairperson, at the outset I would like to thank Dr. Pirama for asking me to talk on this topic, anemia in inflammatory bowel disease. Usually neglected, undertreated, and more often, nobody bothers about anemia when it comes to IBD. It does have a major role in terms of symptoms, and in terms of management. It is quite difficult to manage anemia in IBD unless otherwise you are really keen in getting to the bottom of what is causing that and treating it. In the next 15-20 minutes, I'll just go through. I have purposefully made the talk very simple so that the essence of the talk will get in and people will start managing the anemia better. Just to start off, what we will cover today is that why it matters. We'll look at the burden, prevalence and impact on the quality of life. I look at the pathophysiology, whether it's iron deficiency, chronic disease and overlap. Third is about recognizing it, symptom screening and when to treat. Fourth is about diagnostic workup, labs interpreting ferritin during inflammation, and the last is the management oral versus IV iron. Just to make you understand that it's very, very important to note that 45% of your IBD patients will develop anemia at some point of the time in when they develop IBD. It's an epidemic of silent suffering. 68%, nearly 2/3 of your IBD patients, particularly inpatients, do have anemia. Anemia represents the most, when you call extraintestinal manifestations, we are always worried about many other things like eye manifestation, joint, skin, liver, bone, but we never bother about anemia. Anemia is the most common extraintestinal manifestation of IBD. It's underdiagnosed, as I told you, 68% in inpatient. The chronic status of anemia is directly the chronic status of anemia directly correlates with hospitalization frequencies, longer clinical stays, immediate negative impact on cognitive and physical quality of life metrics that often outlast the mucosal flares. Again, the data, as I told you, in inpatients it's about 68%. In stable outpatients, the anemia is about 20%. When you look at Crohn's and ulcerative colitis, in Crohn's, the prevalence of anemia is about 27%, and in ulcerative colitis is about 21%. It is important, more common with longer disease duration and greater inflammatory burden. The longer the disease and more inflamed, or there is more inflammatory burden, you often find them to be anemic. As I told you, it's frequently undertested and undertreated. Why anemia matters? 1 in 3 complications, be it Crohn's or ulcerative colitis, 1 in 3 suffers from anemia. The threshold is 13 grams for men and 12 grams for women. Common symptom, fatigue. Fatigue is a key symptom in the foundation pathway and should trigger recognition, testing and follow-up. Although we always see when an IBD patient comes to you telling that I'm being fatigued, but most often we look at only the IBD part, we forget to catch up with this anemia. It's often missed. It deserves attention because it has a bad impact on the quality of life. Patient has fatigue, breathlessness, poor concentration, and it also impacts the overall quality of life. It correlates with the disease, often tracks the inflammatory burden and flag undertreated disease. Suppose the patient is anemic, and it's very likely that this patient may have a severe disease. It utilizes the health care which is meant for other purposes, and it involves longer hospital stays and higher costs, often overlooked. Now, just to take you briefly into duodenal iron absorption, which is where iron gets absorbed, just consider on this picture, the dietary iron through the apex of the enterocytes gets in, and the other source of iron for circulation is, in reticuloendothelial system, the senescent RBCs are broken down, hemoglobin is broken down, the globin portion is taken out, heme portion is broken down, again iron is synthesized and stored in the macrophages. So from here it has to get into the plasma, then it binds with transferrin, and that's what is available for production of hemoglobin. So there is something called, between the enterocyte and between the macrophage, you have got something called ferroportin. Ferroportin is nothing but a gatekeeper of both these areas. So this is influenced by a peptide hormone produced by the liver called hepcidin. Hepcidin is related to inflammatory marker IL-6. Whenever IL-6 goes up, any inflammation, IL-6 goes up, increased hepcidin is produced by the liver. What this hepcidin basically does is that it just comes and closes off the ferroportin. It just closes the gate. So iron cannot leave the enterocyte, iron cannot leave the macrophage. So in spite of large amount of iron, you have very less amount of iron leaving into the plasma, leaving the body iron starved despite the presence of iron. So whenever there is inflammation, hepcidin will go up, and this is how the anemia of chronic disease happens. So regarding the mechanisms, there are two overlapping mechanisms. One is the iron deficiency anemia due to chronic mucosal blood loss, reduced dietary intake because of flares and dyspepsia, malabsorption, particularly if there is duodenal Crohn's disease or extensive mucosal disease, then you can have iron deficiency anemia. Anemia of chronic disease, that's what I just explained, through the ferroportin hepcidin pathway. So many a times both can combine together. When iron deficiency, where does the iron goes? Mucosal inflammation, ulceration and friable mucosa cause oozing and often occult GI blood loss. There is reduced intake because of pain, nausea, and during flares and patient feeling unwell. There is also impaired absorption due to mucosal disease. Anemia of chronic disease, the hepcidin pathway we have already discussed, and most often you don't get a pure disease of iron blood loss, or you don't get a pure component of chronic disease. You have a mixed picture. Most often it's a mixed picture, but there are also other contributors like B12. There is also B12 deficiency, particularly in terminal ileal disease. Folate deficiency can happen particularly with sulfasalazine or methotrexate. Drug induced, particularly when thiopurine induced bone marrow suppression, can happen. Rare causes hemolysis and myelodysplasia. So what is important is that once the patient becomes anemic, treating the patient as a whole, you should start recognizing anemia. What are some of the recognized symptoms? As I told you, fatigue, breathlessness, pallor, poor concentration, palpitations, reduced exercise intolerance. It has a multi-system impact. The patient has a brain fog because of poor, low levels of hemoglobin. The patient gets clogged, can have severe concentration failure, can have memory loss, short-term memory losses, and heightened depression risk. Cardiovascular compensation of anemia, most people know it causes compensatory tachycardia, shortness of breath, significantly elevates long-term chronic heart failure risks. And third is, you've got to understand that iron is an important, indispensable cofactor for collagen synthesis and cellular repair. So whenever there is anemia, whenever there is iron loss, you are forced to have the mucosal healing gets delayed. And apart from it, a low level of hemoglobin increases the platelet count and increases the risk of thromboembolism. So when do you screen the patient? When the disease is active, you have to screen the patient for anemia every 3 months' time. Once he is in remission, you have to do it every 6 to 12 months' time, and in newly diagnosis, at diagnosis, and then per activity. As now, depending upon the activity, you have to screen him for anemia. The core panel of tests include CBC, ferritin, CRP, and transferrin saturation. The transferrin saturation is calculated from serum iron and serum iron binding capacity. So the key trap in IBD is that often there is significant inflammation, CRP goes up, and most of you know ferritin is an positive inflammatory marker, so it tends to go up particularly when there is active inflammation. So the best way to diagnose is that look at the ferritin level. If it is less than 30 and if the CRP is normal, do both at the same time. If CRP is normal and the ferritin is less than 30, it is certain that the patient has got iron deficiency. The next is Look at the other end of spectrum, which is the elevated CRP. When the CRP is elevated, look at the ferritin levels. If the ferritin levels is still less than 100 despite an elevated CRP, very likely that this patient is iron deficient. But then if his ferritin is between 100 and 300, then calculate the transferrin saturation. Transferrin saturation is normally somewhere between 20, there are different scores saying between 15 and 45, some saying between 20 and 50. The European standards are between 20 and 50. Any transferrin saturation less than 20, in spite of an elevated ferritin, then it's very likely this patient has got anemia of chronic disease with iron deficiency. So the three pillars of management: one, you have to replace the iron. There is no point in keeping on replacing the iron without treating the original disease, which is to treat the inflammation. If you treat the inflammation, that you will be able to clear that hepcidin pathway and you will be able to treat the anemia of chronic disease. And after you treat, recheck the labs, retreat as needed, watch for recurrence of anemia. Oral iron, a bit about oral iron. It works well when the anemia is very mild and the patient has got a quiescent disease. It's low cost, widely available, and even if you use it on alternate days, you will be still able to get a decent level of hemoglobin. But its limits are that it causes GI side effects, which most people are aware. There are different iron salts available. Some say that this is less toxic to the stomach, this, that. But I have to tell you that most iron salts certainly irritate the stomach. It's poorly absorbed during active mucosal inflammation, and apart from it, it takes a long time for the correction of anemia. Now, most of you are aware that we now use a lot of IV iron. There are multiple compounds available. One is called as ferric carboxy maltose. This is something comes in the name of Ferinject. I think that the only thing is that you have to understand you cannot use this molecule for more than a gram. So at a time, if you want to give an infusion, the maximum allowed dose is only 1 gram. The next is ferric deriisomaltose. This is the isomaltose compound, comes in the name of Gilaso, and this is one of the best compounds which has got the least chances of reactions. Apart from it, you have to calculate the amount of deficit using the Gazzoni formula. You can give the whole deficit in a single infusion using this molecule ferric deriisomaltose. The next is iron sucrose, which is an established option but typically requires multiple sessions, not like the one that when you use these two compounds. So how much to give, you can calculate using Gazzoni formula, where you look at the present hemoglobin, target hemoglobin, age, weight and other things, and you make up the need and you can give it as infusions. Now the controversy was the case against oral iron. When you give oral iron, particularly in an active disease, what happens? You have to understand that when you continue to give oral iron in an actively inflammatory bowel disease and the iron fails to be absorbed, then this iron is likely to be the cause of further and frequent flare if it gets unabsorbed and goes into the colon. Number 2, it is a fertile soil for dysbiosis, particularly unabsorbed iron goes and causes dysbiosis by growth of bacteria, and apart from it, it can also make the patient feel worse by causing severe abdominal pain and GI side effects. For IV iron, one thing is that, as I told you, that once you have anemia of chronic disease, which is what makes up most of the cause of anemia in IBD, when you give IV iron, it bypasses the hepcidin pathway. It is straight away taken up by the transferrin, it saturates the transferrin, and henceforth it is available for hemoglobin production once it's given as IV. So you have a direct bypass of the hepcidin pathway. You need not go in, you can do a total dose replenishment depending upon the iron compound you use, and apart from it, the third benefit is that giving sufficient iron results in rapid healing. just a tabular column to show you the speed of correction between the oral and IV iron, slower and faster. GI side effects are more common here with oral, but well tolerated intravenous. Efficacy wise, obviously IV iron is better, but cost wise it's slightly more. But when it comes to the benefit, IV iron is much better than the oral iron. Now this is to show you the most important thing, the hemoglobin recovery at 4 weeks. The hemoglobin recovery at 4 weeks is defined as more than 2 grams increase in hemoglobin from the base value. If you use IV derisomaltose, you can see 92% of the people increasing their hemoglobin by more than 2 grams, and the same with carboxymaltose by 84, and a standard oral iron 1/4 of it, just 22%, and a placebo response was just around 4%. So monitoring, what do? Recheck after you start treating the patient, recheck the ferritin at the end of 4 weeks time after starting the therapy, and then periodically you have to keep checking the ferritin, CRP values and other indices that you need to check for the type of anemia, and always retreat as and when required. Most important, the base is not only replacement of iron, you also have to treat the underlying inflammation, including immunomodulator therapy, biologics or oral small molecules to treat the underlying inflammation. In pregnancy and IBD, you have to screen every trimester. IV iron is favored over oral iron in pregnancy because the correction is faster and better. Pediatrics, same principles apply, but when it comes to growth and development, because this is more important in children, the stakes of untreated anemia is very heavy, and it is important that these people are treated better with IV iron. So the simple bedside approach would be is that recognize whenever there is anemia, please recognize symptoms such as fatigue or bleeding or routine labs showing low hemoglobin. Recognize the anemia, assess the activity. Is this IBD active? Then you have to combine treatment of anemia along with treatment of the IBD, and again if there is severe inflammation, then better than oral, go for intravenous iron replacement. Classify the anemia, whether it's iron deficiency, whether it is chronic disease, mixed, or whether there are adding factors like B12 or folate. Do replace them appropriately as required. Treat and cause the deficiency, correct the iron deficit, control the underlying bowel inflammation, and as well as reassess, check the response, retreat appropriately as needed. The key takeaways are anemia affects up to 1/3 of the IBD patients and is frequently under-recognized. 2 mechanisms usually combine iron deficiency and anemia of chronic disease. Always interpret ferritin along with CRP because inflammation masks the true iron deficiency. IV iron is preferred in active disease and oral iron in quiescent disease. Treating the underlying inflammation is essential. Iron alone won't fix the anemia of chronic disease. Thank you very much.
Thank you, Dr. Harry. I think that was very crisp. I mean, no points were missed, and it was done in 10 to 15 minutes. Thank you, Dr. Hariharan. I'm sure if there are any questions, Dr. Hariharan will be very happy to crystal clear. I don't know. There are some people who say if you don't ask questions, either it goes completely above the head or you understood everything. I think this was one classical example of somebody who has explained everything in 10 minutes. Thank you very much, Dr. Hariharan. Thank you.
Yeah, sure. Dismiss anemia. Don't dismiss anemia as ordinary thing. He has made it very clear.
We have a panel discussion on choice appropriate drugs in treating inflammatory bowel disease. And no better person than Dr. Basumani to do this for us. Now, in my experience, you see a lot of guidelines, and it's universal. WHO has guidelines, every country has guidelines, you have American College of Gastroenterology giving guidelines. But most often, we read the guidelines but treat according to our own knowledge, patient specific. There are so many factors that goes into such things. It can be monetary, it can be the availability of drugs in those situations, and so on and so forth. So Dr. Basmani here is to tell us what the guidelines show. Huh? Oh yeah, we have a panel. Dr. Arun, where will they sit? Dr. Arun, please come take the stage. Dr. Babu Vinish from MGM. Thank you. Dr. Raja Yogesh, Med India, my excellent colleague. And Dr. Vishnu Priya Rajagopal from MB Diabetes. So Dr. Basumani, the next 45 minutes is all yours.
1 hour, yeah?
1 hour, okay. Take your time.
Madam, எவ்வளோ டைம் கொடுத்துருக்காங்க?
No, take your time. But we'll adjourn for dinner.
Good evening, everyone. I thank Brahma. Whenever I get a phone call from him, I now start shuddering. So he has given me this task, but what he did was he compensated to give me an excellent panel. No, so all of them I'm very lucky to have. Thank you, sir. Thank you, madam. Respected Professor Raghuram sir and my good friends. So when I was riding a rally cycle, no, life was simple. Pedal, puncture, and so the more electrified vehicle and electrical car and more complicated mechanism comes, no, and I am getting to grapple all the things. So all of us are familiar with the therapeutic ladder of IBD, which was unchanged for a very long time. Now, for several decades, there were steroids, and then sulfasalazine came, and that became 5-ASA. And then thiopurine and methotrexate came. Occasionally mycophenolate was also used. And then much later we used to put them on biologics, and that's it. And wait for the Almighty to do the job. But all of us were aware of significant unmet needs. They usually manipulate the graph. The placebo will be 30% and therapeutic arm will be 40%, but in the published graph it will look as though they are very, very different. So the maximum response of even adalimumab, in the primary response was 40 to 60% with the frequent secondary loss of response. So we all knew that there was no magic bullet and the holy grail was still going on. So with more kids, new kids on the block, the clinical thinking should change from what should I choose next, which drug should come first, rather than what is the ongoing mechanism that is currently on board, and if the patient is not doing well, what mechanism is appropriate. Now you should think more like I said, the mechanic or some kind of technician rather than just a consumer of a product. So in India we have available established anti-TNF agents, the chimeric infliximab and fully humanized adalimumab, and not to mention plenty of biosimilars. We have gut selective anti-integrin vedolizumab, IL-12/23 P40 inhibitor ustekinumab, and we have oral JAK inhibitors, tofactinib licensed for UC, whereas Upada is licensed both for UC and Crohn's. These are the armamentarium we have, and our panel is going to ponder at every clinical scenario where we go from at the point of change. So the plan of my panel discussion will be the new unmet need. With greater choice, we all struggle in front of the patient, scratch the head, ask meta-AI. Ravi sir taught me how to use meta-AI, so you usually ask meta-AI in front of the patient, where to position the next mechanism. For that, I think 13 parameters I need to think, Human beings cannot handle more than 4. That's why most of the bank card PIN numbers are only 4. So 13 parameters. You can read phenotype, how much tofactinib will act within 2 days, speed of action, what is the previous mechanism, is there immunogenicity, external manifestation. Now I learned one point, anemia, but if somebody has external manifestation, you don't go only for a gut selective anti-integrin rather than you go for a more systemic therapy like biologics. Is it a picturizing disease or stricturing disease? Is this a post-op situation? What is the age of the patient? No, the patients I see and patients Madam C are different. No? Some are not licensed for pediatric use. Doses are different. Concerns are different. Patients are overpowering. Situation is different. And for certain molecules like JAK inhibitors, we need to look at the cardiovascular profile, risk of venous thromboembolism. What is the family planning of the patient? You know, for example, methotrexate cannot be given even to a male if they are planning a family. What route of administration they prefer? No, somebody would want to be regular with IV infusion at the hospital rather than left on their own with a subcutaneous infusion. What is the affordability? Because India, Vadivel will say, no, beginning எல்லாம் நல்லா தான் இருக்கு, but finishing தான் சரியில்லைன்னு. We can always start with a ideal therapy, but if they cannot even continue for another 3 months, 4 months, then you are unrealistic. You are not a clinician there. No, you are just unthinking technician. And the patient preference, because it is patients say no decision about me after discussing with me. You know, so that they are partners in decision making, shared care. That kind of therapeutic relationship is what placebo response says. Now, IBD patients demand a separate doctor-patient relationship. I think it's highest. If you run an IBD clinic, if you see 10 IBD patients, I'm sure you will need a strong coffee after that. So they zap your emotions. So whenever we say failure, that is a decision-making point, a nodal point. You need to again think, apart from those 13 points, is it truly inflammatory? Because bile acid malabsorption, ileal resection, SIBO, some kind of medication effect, so many things can masquerade as so-called mucosal flare, but it may not be truly mucosal flare. So, on the other hand, if it's a mucosal flare, some of the cases will illustrate whether it is due to underexposure, immunogenic failure, or the total mechanistic failure where you need to think of out of class rather than within class switch, or is there a completely irreversible structural damage where throwing one more medicine or two more medicine is not going to work. So with the panel's help, we have curated 4 illustrative cases, one post-op Crohn's, one secondary anti-TNF failure in a lady with UC, a young man with a medically refractory stricturing Crohn's disease, and a young girl with a pediatric perianal Crohn's disease. And again, I am very grateful for the panel for chipping in and then putting their effort to clarify the therapeutic dilemmas or crossroads. So they will not only give their choice, but they will crystallize their thoughts, how they arrived at the choice, what outcome they expect, and more importantly, it's not the beginning, it is journeying with the patient. Now, at what point, at what are the things they will look at. Thank you. So this is our first patient, a 23-year-old engineer with ileal Crohn's disease diagnosed 3 years ago. He was on azathioprine, but he self-treated with prednisolone after the initial prescription, 40, 30, 20. Then whenever the pain increases, he will go back to 40 and then 30, 20 like that. It's like a parama bubble for him, which is not uncommon because once they, like levosulfuron, now once they find some benefit, they don't come back for repeat prescription or assessment. They self-manage. So, but eventually he returned to the clinic because of recurrent subacute obstructive symptoms, and the CT angiography confirmed a short fixed terminal stricture and a small contained collection, suggesting that's another point. Now, most of the penetration occurs in conjunction with the stricture, even though the Vienna says inflammatory, penetrating and stricturing disease. Some of the penetrating disease is actually because beyond the stricture, the bowel dilates and then thins out, and perforation comes as a aftermath of severe stricture. And the proximal dilatation is important, because if there is a significant proximal dilatation, then you think between the two component which is more dominant, you need to think. So immediately he underwent the ileocolic resection a month ago and he is recovering well. He came for review and the histology has confirmed active transmural Crohn's disease with fibrosis. Fortunately, the margins were clear of the disease. Unfortunately, despite medical advice, he continues to smoke, and he is a DJ of night events, so his sleep pattern is awful. He is an event manager. So he has no previous biology exposure, no, only use of azacitidine, abuse of corticosteroids, and then he asked sitting in front of the clinician, the disease segment has been removed. Do I still need expensive another medical treatment? For that we have Raja Yogesh. So Raja, is early surgery itself sufficient to classify him as high risk?
First to answer the first question, sir, most of the patients who have undergone a surgery have that phase where they are relatively asymptomatic. So one thing that we have to have in mind is that surgery merely treats the complication of the disease, and whereas the underlying disease is still going to continue. So at this stage, even if the patient feels no symptoms at all, to wait for the symptoms and then treat, then we might be actually missing the bus, because the ongoing inflammation is going to continue, and we have to make sure that the disease is treated aggressively even to start with. So coming to the second question, is early surgery itself sufficient to classify him as high risk? Of course, surgery per se may not be the risk here, but the pattern in which the disease has evolved is what shows us that it's a high risk case or a very aggressive phenotype. Because it's a young male, that itself is a risk factor. And then he was diagnosed, I suppose, at 20 years of age, and within 3 years, the disease has progressed, and it has progressed to such an extent that it has necessitated a surgery because of the stricture. So that indicates a very aggressive course of the disease, again, putting him at a high risk for a recurrence and a future surgery. The other factors this patient might point us towards an aggressive disease is that, of course, he's a chronic smoker is what we see. Smoking is an independent risk factor. And the fact that he's required steroids and he's almost steroid dependent, abusing steroids by himself, self-medicating, again is a risk factor, putting him at a risk for a recurrence. So this patient definitely would require a very aggressive management to start early on, rather than wait for his symptoms to develop and then start treating the patient.
Not to forget smoking, ongoing
smoking.
In some data sets, even presence of granuloma and the plexiform neuritis in the resected specimen, they put them at high risk. So stricturing disease, early surgery, recurrent surgery, smoking, age of onset, everything. But any third year PG? Final year PG? One of you? You are my temporary panel, yeah. So Raja said the disease was progressing in the last 3 years, but do you think he was adequately treated in the beginning? No, sir. So do you think azacitidine and corticosteroid was what the ECHO guideline will say?
Sir, considering his high risk factors, he should have been initially in the top-down therapy, sir.
Yeah.
So, if
excellent. I think you conveyed the point. Yeah, that's what we said. No, we use biologics late, but at least now that in the post-op stage, you don't take the same backseat. No, don't wait for the flare to come. But let's proceed with the third question. So second question. So he has been on steroids for almost a year, Raja. So how does it color your or shade your assessment?
So again, steroid dependence would indicate that it's a very aggressive disease. And the second point here is that during the perioperative period is what we have to keep in mind. Steroids, if the patient is already on steroid and if it's going to be an elective surgery, then steroids necessarily have to be tapered and then stopped before surgery is contemplated. And ongoing steroids, if it's going to be an emergency, of course it's going to have less favorable outcome as to compared to a patient who has not been on steroids. Mostly this would be related to the perioperative period of perioperative infections, delayed wound healing, more chance of anastomotic leaks. And of course, then the question of stopping steroids. A patient who's been on chronic steroids never stops steroids abruptly. They have to be tapered and then stopped to avoid an Addisonian crisis. So that is the second point.
If treating IBD is Mahabharata, no, steroids are like Nagastra. No, use only once. Don't even think about. You clearly write in the initial prescription. This is 25th July. This patient will come off this prescription 25th September or something. That if you don't write exit, you don't have a right to prescribe steroids. You have to prescribe the exit. For perioperative cover, sir, I think hydrocortisone will tide over. So, but definitely endocrine opinion. No, if you go through guidelines how to taper steroids and monitor them for next several years during crisis, you will not write steroids at all for any patient. So we have several new kids, Raja. What will you choose for him now?
We have the convenience of orally available small molecules, but the robust evidence in this setting would be more for anti-TNF agents rather than upadacitinib and tofacitinib. That's where the evidence is most strongest. And in this case, I would rather choose infliximab. Second choice would be adalimumab. And of course, if they are not tolerated or the patient is not doing well, that is when ustekinumab or vedolizumab comes in.
So if he prefers subcutaneous, he will go for adalimumab. If he doesn't mind the IV, infliximab has got the greatest evidence.
Yes, sir.
But for risk covers or high risk profile, you can go for less. But for post-operative prophylaxis in this high risk patient, I think anti-TNF has the best.
Anti-TNF is the best.
So when will you start it? Now, not after the recurrence.
Guidelines have changed of late, but if the patient had been already on anti-TNF agents, it's better to continue. So in this patient, almost 4 weeks, I think would be the ideal time. 4 to 6 weeks, I think. Make sure that the patient doesn't have any complications, the wound is healed, no perioperative collections.
You will
infection rule out, and then we have to start.
You will go through all the precautions, vaccination and infection screening, but assume we have done all that and is clear.
Then I think it's the right time to start.
So he does have rest of the bowel normal. That is why we have seen patients who had ileal resection and never looked back for 30 years. But given this patient profile, this young man who smokes, who has got a poor lifestyle, who had both penetrating and perforating disease. So his risk profile says that he will benefit from proactive prophylaxis rather than passive waiting and then jumping in with the agent much later. Subal, that's exactly the patient is asking. No, the disease segment has been removed.
The ileal segment, the phenotype is more important, particularly if it's a non-penetrating, non-structuring phenotype, isolated ileal resection, that you can follow it up for a long time. This fellow has got a very bad phenotype. He's got structuring, complicated.
I think that's a different disease. In the previous conference, Prama will remember. We just do resection and then leave it. Is that only treatment?
For that you can probably consider ileal resection, forget it. But this fellow has got all sorts of complications. His phenotype is bad.
I think that's why I chose this case. He's a real patient. Anand knows this way. But the thing is, if he has disease elsewhere, perianal or proximal small bowel and colonic disease, it is not a point of contention at all, because he needs treatment. The thing is, this kind of proactive treatment with a costly agent with the potential side effects and effective screening and ongoing monitoring is the paradigm shift in the thinking.
We should follow that. If he is such a bad patient, will he follow all this biological? Will he take this regularly and then continue the treatment. This is a, what is the exit?
You always take me to the last slide.
What is the exit for
patient autonomy, sir? See, there is something ideal and there is something else practical, so you can only give him the choices. So for example, in acute severe UC, infliximab is the best evidence, but if they don't want it, I have lost a patient, they didn't want it. So we can give the evidence base and then ask them to come back and then think and then give, or offer a second opinion, go and discuss another senior gastroenterologist with interest in IBD. All these options are there. But at the end of the day, an adult who has compasmentis will decide what he or she wants or does not want.
Sir,
that is always there.
This for sir's question, he is quoting lyric study, but eco guidelines are there. If the patient is shorter duration between diagnosis and surgery, this is a shorter duration of 3 years. And if he is a smoker, dominant stricture with pre-stenotic dilatation, these are all indications for post-operative biologics. This is echo guidelines. So there is no doubt about it.
I think
the lyric study does not apply to this patient.
That's the point, yeah. I agree. So,
the point to add is the stricture, which was appearing fibrotic, but when we go through the histopathology in this case, it stated that there was ongoing transmural inflammation was going on. It was not a purely fibrotic stricture as what the imaging gave us.
What about azathioprine?
Azathioprine, not as a monotherapy, because we know that azathioprine will not help in a severe UC, and already patient has been on azathioprine, so there's no point in continuing azathioprine as a monotherapy. If we are choosing infliximab, that is when we...
Question to postgraduates. One of them can, if they know the answer, raise the hand. So what is the rare but deadly fatal complication reported in young men receiving a biologic and azathioprine long term? If it comes, then they are dead. So that count will go. If you want to add azathioprine to reduce the immunogenicity with infliximab, there should be explicit counseling about this rare deadly complication. Hepatosplenic T-cell lymphoma. So our theme now. So now that you will start, and he agreed. Despite Ravi sir's anguish, he has agreed, and he is a regular now. So because he is feeling the need for avoiding another surgery, So how will you monitor him? What is your timeline?
Of course, we have the STRIDE 2 guidelines.
STRIDE is the keyword, yeah.
STRIDE 2 guidelines to give us a general outline, but in this case, being a high-risk case and perioperative exposure to steroids, the clinical review I would probably have him after discharge in the first 2 weeks to make sure that there's no concurrent infection happening in the perioperative period. And of course, we'll have to monitor the patient's symptoms as well. And one caveat here is that symptoms don't go purely relying on symptoms, because symptoms lag very much behind the disease process. So symptoms might give a clue, but not entirely. Don't rely purely on symptoms, because we have the markers, the CRP and the fecal calprotectin. At least do them once in 2 to 3 months. That's the guideline. And the most important of all is to do a colonoscopy. Of course, any deviation, any new...
When will you do it?
It has to be done at the end of 6 months. That is when you assess for the evidence of any mucosal recurrence. Of course, there can be 2 types of recurrences. One is the anastomotic recurrence, and one is the recurrence in the neoterminal ileum. So any recurrence which is there in the neoterminal ileum is much more significant than an anastomotic ulcer. So look for ileocolonoscopy at least at 6 months, and if there is going to be any evidence of mucosal, high-grade mucosal injury, then we know that we are not on track. We have to either switch or we have to augment therapy. That is what that we have it here.
So another scenario, he did not accept biologics, and then he had a relook colonoscopy 6 months later. He had Rutgers I2B.
So So this is the modified Rutgers score, which was initial score was in 1990s when they were thinking of chance of recurrence following surgery, and of course this has been modified. So any grade which is greater than 2B again, it indicates that the inflammation in the neoterminal ileum is significant, irrespective of the presence of anastomotic ulcers. So anything greater than 2B, that is I3 or I4, it indicates that the treatment has not been working, and definitely there's a high chance that the patient lands up again with surgery or other complications. And here the patient has not agreed for any biologics. So this is again gives us a
Now we'll
point
renegotiate.
where we tell them that it has progressed and we need to switch to therapy.
To summarize, so as Raja clearly said, no, post-op recurrence is commonly silent. You need to risk profile and then proactively give post-op prophylaxis. Anti-TNF has the best evidence. Only when they are unsuitable or fail, you can go for newer molecules. And monitoring should be proactive, objective, and timeline bound. And as I said, this patient was undermanaged, as the floor agreed. Thank you, Raja. Now we move to Vishnupriya. So this is a secondary failure of adalimumab in a lady with ulcerative colitis, which was extensive for 6 years. Despite oral and topical 5-ASA therapy, her symptoms and endoscopic activity did not heal. She became steroid dependent despite azathioprine, and quite rightly 2 years ago she was switched on adalimumab. At that point she improved clinically, biochemically, and she underwent steroid free remission for more than a year, but the honeymoon stopped 3 months ago. She relapsed with frequency, urgency, nocturnal diarrhea and intermittent rectal bleeding, and inflammatory markers were high. So stool culture C. diff negative, sigmoidoscopy shows moderate activity by endoscopic index of severity. She reports a good adherence to adalimumab. She has history of hypertension, dyslipidemia. However, there was no previous cardiovascular event or venous thromboembolism. She works as a teacher in a remote town. She strongly prefers oral or self-administered treatment, and she desperately begs you, no, doctor, don't send me to the surgeon. Very easy, no? Easy clinical situation for you.
Yes.
So what would you do?
So this is a case of a moderate to severe ulcerative colitis with initial response to adalimumab, now presenting with a secondary loss of response.
So this is not acute severe UC, which is a distinct clinical syndrome. We will need admission. That's a medical emergency. Postgraduate. This is not ASUC. This is moderate to severe UC, where ambulatory care is still acceptable. Yeah.
Presenting with a secondary loss of response in spite of good adherence to drug, and infection is excluded and inflammation is confirmed. So I would like to get adalimumab trough levels and anti-drug antibodies to determine what we are dealing with, whether it is a pharmacokinetic failure or mechanistic failure.
I will give you. I will make life easy for you. It is available in Chennai, and we did for this lady. But hypothetically, I am giving you 3 scenarios. Scenario 1, adalimumab level was low, no antibodies.
Okay, so the first level, low levels with no antibodies. This is a non-immune mediated pharmacokinetic failure.
Under exposure, yeah?
Yes.
Yeah.
So here, I would like to optimize the current adalimumab dosage, whether to increase the, whether we will increase the dosage or increase the frequency of the drug.
Right. I think all of you will agree. Now, some of the patients are rescued, and I have several patients on weekly adalimumab, again running good for another year or so, touch wood. Okay, the second scenario is low level with high titer antibodies.
So this is a immune mediated pharmacokinetic failure. So here the ideal would be to switch to other anti-TNF like infliximab.
Infliximab. But you heard her, no? She doesn't want
yes.
Institutionalized treatment like infusion. She wants self-administered treatment. So I will give you the third scenario. So she has adequate level with active endoscopic disease. No, I think that's the 2 situation, no? low level, no antibodies, that's fine.
Yes, the last is adequate level with active endoscopic disease. There is a mechanistic failure. So here we have to switch out of the class.
So
Drug
this
with
is
the different mechanism.
The first one is low exposure.
Yes.
The second one is immunogenic failure, and
That's
three is
mechanistic
this is the
failure.
proper. This mechanism has failed. So within class switch is not appropriate. You need to
Switch
choose
out.
This is the our first slide said. It's not what drug next, what mechanism next. Yeah. So we only have these three. She had the third situation. We have Bedo, ustekinumab, and JAK inhibitors. Both JAK inhibitors are approved for UC.
So we determine my choice like based on the drug efficacy, safety, onset of action, patient comorbidities, and patient preference. And vedolizumab, yes, it's excellent safety profile, gut selective, but slower onset of action. And coming to ustekinumab, patient prefers subcutaneous, it is subcutaneous and has a good safety profile, but it is expensive. Coming to JAK inhibitor, yes, it has a stronger efficacy after TNF failure, but here considering the patient age and comorbidity risk, I would like to do a careful risk assessment before starting the patient on JAK inhibitor.
Okay. So real life scenario, she could only afford tofactinib. Touch wood, she hasn't had any major cardiovascular or venothrombic complication. Her symptoms resolve within a week, and she's doing well. Okay, I think you have answered that. So in this lady, what will be your because this is a recurrent theme. You just don't treat, and then as Raja said, no, patient reported outcome measures, PROM. When I started IBD clinic 25 years ago, I'll be dreading the next patient. When they say, I'm doing fine, no, immediately you repeat all prescriptions, send them away. No, because that's what we wanted. If they have no major symptoms, now we are talking about deep healing, mucosal healing, histological healing, and even molecular signature healing in the past. So, but here, for this lady, what will be your objective reassessment goal?
Same, I follow the treat to target approach. Initial, I'll have like a short-term, intermediate and long-term approach. Short-term, within 2 weeks, I would assess a clinical response, reduction in the stool frequency and reduction in the rectal bleeding. And by 8 to 12 weeks, look for the biochemical, that is intermediate target, normalization of the CRP and reduction in the fecal calprotectin levels. And long-term would be like endoscopic healing after 12 weeks to see like what is the Mayo score, whether it's a 0 or 1.
So these are the take-home points, no? So pharmacokinetic failure, we can optimize or consider within class. Immunogenic failure, we need to address antibodies or switch appropriately. If it's mechanistic failure with adequate exposure, you need to switch out of class. So this is called a reactive TDM. No, you therapeutic drug monitoring because the patient is in trouble. There is another situation called proactive TDM, which will be illustrated in a different case. So this prevents empiric and inappropriate, knee-jerk response of switching from this and that without a rational thinking behind it. Case 3, Babu. So here we have a different scenario. I chose 3 Crohn's because I think they produce more complex clinical scenarios, only one UC. So this is second Crohn's of the series. This is a 35-year-old lady with ileocolonic Crohn's disease, and she is documented to have 7 centimeter terminal stricture. She comes from, again, a faraway town, and the previous MRI showed mural thickening, hyperenhancement, and restricted diffusion, along with the fixed narrowing. So there was some mixed inflammation as well as fibrosis. Symptoms were mainly signs of obstruction. She had no clinical or radical improvement on adalimumab despite prolonged adequate exposure. Later, she was switched to Upada. Her CRP and calprotectin improved, but the pain and obstructive episodes continued, and imaging showed persistent pre-stenotic dilatation. She went to get a surgical opinion as per your advice, and the surgeon working alongside you has strongly recommended that she needs ileocecal resection. However, she and her husband firmly refused surgery. They have morbid fear of stoma, and they sincerely pray and hope, no, some more medicine, a different biologic, something else will do the miracle. So, is medical treatment going to be futile? So for that you need to answer within you first before answering the couple. How do you distinguish inflammatory stricture from fixed stenosis?
So as you were telling in the beginning, not all Crohn's strictures are purely inflammatory or purely fibrotic. We have to find whether it is inflammatory or fibrotic. By clinically inflammatory, the patient will have fever, diarrhea, elevated CRP, calprotectin. If it is more of a fibrotic, it will be weight loss, obstruction like this patient. But the diagnosis can be given by an MR enterography. When you have T2 hyper enhancement because of the water content of the inflammation, diffusion with a restriction in an MRI, and if you have that will suggest inflammation. If there is an upstream dilatation with a fixed stricture, it is fibrotic. But nowadays, if you go A general, they are telling contrast enhanced ultrasound, but I have not done. So if anybody has done, it is fair enough.
I don't think people go to Hyderabad, but nobody has come and established intestinal ultrasound service yet, I think.
Okay, and here in this patient, if you see that ADA has failed.
Yeah.
And UPADA has caused biochemical improvement in symptoms, but she has a biochemical response, but she has symptoms. So the bowel itself has told, I am not going to work anymore, send me for surgery.
So you are not going to, that's what, just because something is available, that doesn't mean you can keep on dilly-dallying with it. That's important. In buffet also, no, so many items will be there, but do you really need it? No, go away from it. No, if you are full, then go away. No. So you saw the MR description, no? Would you? They have heard of no? They have consulted some other person, especially with Chat GPT and all. No, they think, doctor, can't you dilate it? No, spare me the surgery.
Okay, the thing here is outright answer will be no only, because all guidelines tell 5 centimeters. If a stricture is more than 5 centimeters, for each centimeter more, you have 2.5% hazard ratio. That is, if it is a 7 centimeter lesion, there is a 2.5, that is 5 times the risk the patient will end up in surgery.
Ravi sir will say, one balloon will cover only.
The next point is that only, sir. The next balloon is the geometry. So each CRE balloon is only 5 to 5.7 centimeters. If you are going to dilate a 7 centimeter stricture, you are going to dilate inside the stricture. The third point is, it is a fibrotic lesion. Fibrosis heals by fibrosis only. You might have technical success, but anyway the patient will end up again with fibrosis. And the fourth point is, the stricture is in the terminal ileum. The scope will be in an unstable position and there is a more chance of perforation. All strictures have been, guidelines are for fixed strictures of colon, and more of our anastomotic strictures and not de novo strictures.
We are trying to extrapolate the guidelines which were initially framed for anastomotic stricture, ileocolic anastomotic stricture. Agreed. Thank you. So this couple need, repeated counseling. You need to really bring them towards, nudge them towards surgery.
So what
symptoms would you say that will mandate urgent admission?
I will just educate them about symptoms of portal obstruction, peritonitis, sepsis, because sepsis fever may cause an abscess formation, weight loss, reduction in your clinical deterioration, patient is going into nutrition failure, or if you are repeating an imaging, the pre-stenotic dilatation, if it is increasing, that means the fibrotic stricture is also increasing. The only thing which I will tell is, don't give too much of importance to the pain, because the patient has had recurrent episodes of a subacute obstruction, so she will underreport pain. So you have to find out
just to avoid surgery.
Yes.
Okay. So what do you think? Is it a lone game or a team sport? IBD management.
Sir, already the bowel has spoken. 2 failures. Anti-TNF has failed. JAK has failed. So it is only medical surgical. See, a medicine fellow cannot do a surgical job and a surgical fellow cannot do a medicine. We are not competing against each other. We are together, complementing each other. Okay.
Both I and E, we need to complement the surgeon and we need to complement the surgeon.
So, Kannan sir will resect it. He cannot prevent the stricture.
Sir is smiling, so he is very happy. At least after adalimumab you are giving, no, not after. I hope postgraduates are taking this important point. Now, you are not alone. You should not be alone. So, you feel supported by your seniors, not only in your field. There are experts from surgery, radiology, nutrition, and psychological counseling. No, so it is a team sport, and be a Messi. No, you need the goal, not necessarily from your knee. No.
So the goal of the treatment will be to send the patient before she ends in complications to the surgeon.
Yeah.
Be quick to send to the surgeon.
Imagine after perforation and percussion, sending it to Dr. Kannan sir. So the take-home points are: not every symptomatic Crohn's needs another drug just because it is available in your pharmacy. Active inflammation may respond to advanced therapy, not guaranteed, but established fibrosis and significant dilatation, they will not. A fall in CRP and calprotectin does not prove that the mechanical problem has resolved. Endoscopic balloon dilatation is only for selected cases. Repeated cycling of unwanted therapies delays necessary surgery, and Kannan sir will agree. It converts a safe elective surgery into an unsafe emergency. So, what unmet need that we should write in future perspective in essay question for postgraduate is: there is still no reliable, effective, predictable anti-fibrotic medicine that is in the pipeline.
If it is an elective surgery, if they are on biological, do you want to give a gap of, do you want to stop the biological before undergoing surgery?
Give the mic to Kannan sir. Why I should feel alone? Is there?
Yeah, definitely there should be, I feel at least 2 weeks we should stop the...
And we can use enteral nutrition or something else to boost the... So I saved the best for Arun. He is my favorite anyway. I have a lot of respect for his brains. This is the most difficult case, I think. So, Arun, I am giving a very tough problem. Ready? She is the young girl, 15 years, mild terminal disease but troublesome perianal disease. Initially it showed simple fistula, St. Mark's grade 1, transsphincteric fistula without any collection. Quite rightly, she was treated on with adalimumab as well as azathioprine to reduce immunogenicity. Quite dramatically, her luminal symptoms improved and inflammatory markers settled. However, to our disappointment and to parents' anger, despite your costly treatment, her perianal symptoms have worsened. So this is the question that you dread. Doctor, you are giving costly treatment for those months, but my daughter is getting worse. On examination, your heart sinks. There is now a new external opening. So repeat MRI has confirmed your worst fear. Now it has become a grade 2 to 3 fistula with branches and a small collection. So, madam will agree. Consistent with her age, her adherence has been inconsistent. She hates injections. She is concerned about her body image. She should be. She is only 15. Attending school with very persistent drainage is a real distress for her. So the parents demand immediately change her to advanced therapy, preferably in the form of tablets. I wouldn't like to be in that consulting room. So that's why I sent them to you. So what's the role of seton and drainage, the sepsis control in this situation?
Yes, sir. So this patient has a worsening perianal symptoms and MRI showing new findings of a collection associated with fistula. So she requires a course of antibiotics as well as drainage procedure. The 2025 American guidelines, ACG guidelines recommend ciprofloxacin, metronidazole, etc. as antibiotics of choice as well as placing a non-cutting seton along with it for such situations. And they also emphasize that steroids should be totally avoided in
I think a very, very valid point. Every point. No, I think Satan is not a failure. It is our friend, and surgeon is our friend. No, control sepsis. Find it and control it, drain it, do whatever it takes, because no medicine is going to work in Crohn's unless you clear all the sepsis. Examination anesthesia with a preoperative MRI has truly revolutionized. Previously, it was all blind probing. Now we have a roadmap. Surgeons, senior surgeons help you to drain it, and she will be free of flare-ups in the discharge with a non-cutting seton and a decent course of Cipro and metronidazole. So, she was inconsistent with adalimumab. Would you counsel her optimize adalimumab or switch to infliximab?
Sir, this patient initially had seemed to have a good response and then started deteriorating. There was some question about her compliance also, but still she lost response after initial response, which is like a secondary loss of response. The usual suspect here is a presence of anti-drug antibodies, and first we have to increase the dose of adalimumab to 80 mg once in 2 weeks. If that doesn't work,
much to the chagrin of the parents, they wanted tablets. You are increasing the frequency of injection. Yeah, this is real life scenario. Yes, carry on. Yeah.
If it doesn't work, we have to shorten the dosing interval, and if that still does not work, we should think of probably switching the drug class rather than switching to infliximab. Actually, it is not that infliximab is totally contraindicated in such situations. There is some evidence that in secondary loss of response to adalimumab, it can be tried.
It can be tried.
But considering her age and need for long-term therapy, it may be better to switch the drug.
Postgraduate says infliximab scores over adalimumab in 2 situations: acute severe UC after 3rd or 4th day if the CRP is high, and if you want to rescue the patient after a surgical consultation, infliximab is a better choice. And in perianal disease, if you have to start somebody on infliximab, again has got very stronger evidence base. But there is a catch. I mentioned about proactive therapeutic drug monitoring.
So, sir, in fistulizing disease, it's in general 1.5 times higher drug trough concentration compared to non-fistulizing luminal disease.
Hit it hard. Perianal disease complicates 25% of Crohn's patient, but sometimes that can be the whole game changer. That can be the whole driver of the medical therapy as well as patient suffering. So you aim for trough levels which are 1.5 times more than what you will give for luminal disease. Excellent. So, is there any evidence of continuing azathioprine? She is 15. She is on already anti-TNF. I said men develop hepatosplenic T-cell lymphoma. What about a 15-year-old girl?
So, in the setting of loss of response to adalimumab, azathioprine may not be effective in inducing healing of new fistulas.
No, not as a monotherapy, as an adjuvant.
The main purpose of giving azathioprine is to prevent formation of anti-drug antibodies. So, if we are switching to another drug class, then it's not necessary.
So, questions to seniors. How many of you have people on both anti-TNF and azathioprine on a decent long term? Sure. So all are adults, no? Not young men. Shall we ask madam? You answer, then she can give expert opinion. So, where do ustekinumab and Vido fit in with pediatric perianal Crohn's?
Sir, the ACG guidelines recommends ustekinumab as a second-line drug for anti-TNF failure, and FDA approval is there for this drug for anybody above 2 years with Crohn's disease. So ustekinumab, there is sufficient evidence.
There is
to
a
be-
license, yeah.
Yes, and there is also enough data from Unity Junior study, which gives convincing data about dosing, safety, and efficacy in pediatric population. As far as vedolizumab is considered, it can be still considered as an off-label indication, but in this particular situation, considering the slow onset of response, it may not be.
I think
it will
Vido
be
is
as
much
a-
slower. Yeah. So, what about Upada?
Yes, sir. Upadacitinib actually is not specifically approved for management of
Agree,
pediatric
madam.
Crohn's
In
disease.
pediatrics, I think there is no, but 15 is a watershed zone on a case-by-case basis, no? So, but again, don't feel alone, no? She may be attending Triple M, but pick the phone and then get opinion. No, this is what I'm saying. So, pediatric gastroenterologists have much rich experience. Tap on the resources, no? So, get the help of seniors. Yeah.
Sir, as an off-label indication, it is still there's a reasonable option in this case, and it is approved for patients with psoriatic arthritis about 2 years and atopic dermatitis for
Yeah,
12
only
years.
for our, we always lag behind rheumatologists and dermatologists, no, gastro community, from sulfasalazine days. Right.
So in those patients, no safety signals are there so far.
Yeah. So this is, it will be an off-label, personalized discussion with the family, and as well as getting one more expert opinion before you venture out of comfort zone. So the take-home points are: complex perianal Crohn's requires combined medical and surgical management. You should drain sepsis at all costs. The Satan is not a failure; it is part of success actually. So Kannan sir will agree. Infliximab has got the strongest evidence for complex fistula. For pediatric use, you need to get a multidisciplinary expertise. So, because the patient and the parents demand oral agent for convenience, that should not override inadequate source control or medicines of limited proven value in pediatric population. So to recap, my dear friends and respected seniors, we should always ask ourselves, no, are we treating the true inflammatory activity? A superimposed IBS may be a cause of ongoing diarrhea rather than true mucosal flare. Why did the therapy fail? Is it underexposure? Is it immunogenic, or is it mechanistic failure? What is the dominant phenotype, and will medicine work, or a surgeon's surgical resection is the best interest of the patient? What is the age of the patient? What is the safety comorbidity profile dictating the safety? And never forget, screening for and immunizing. Screening for tuberculosis and immunizing against chickenpox if needed, and shingles, etc. Always, again, whenever in doubt, get the help of ID consultant. Don't hesitate. So then can the patient actually receive? And I think this is the most important. No medical school teaches you this point. So we need to go into the field, face the cold face, and then you will feel the heat. You may read everything and practice and discuss everything, debate for the whole day. But at the end of the day, it is the patient's pocket and the patient's family emotion. In India, we cannot get away from parental, but how long will you use it? How will you monitor it? And what is the exit strategy? There is a beautiful Hindi song. It says, if you cannot complete the journey, if you find a beautiful exit, sideline, just escape. Thank you.
Very excellent panel discussion on this very complicated topic. You have made it very simple and very nice. And as sir said, especially in children during their plus 2 or 10th exam, they deny to come even for the visit or review. And they do not want any injections because they cannot get admitted, especially during plus 2. They are not willing to come for admissions for this. So that is a practical difficulty, and make sure all the vaccines has been given as per the age of the child. No live vaccines during your immunotherapy. That's very important. Growth monitoring is very essential.
You started biological and patient is doing well, responding well. But now they want oral tablet. How will you do it?
நல்லா தானே போயிட்டு இருக்கு. நல்லா போயிட்டு இருக்கு சார். If something is to do with money, because IBD treatment costs much more than combined diabetes, hypertension and hyperlipidemia, and insurance cover is not good in India. So it will be reasonable if chickenpox and shingles is taken care of in UC population, tofactinib. I think that after you can even maintain them on 5 milligram BD. Upada, I'm only getting some grips on it. Vido, 1 or 2 patients. So oral agents are really coming as a boon, as a blessing. But the timing and positioning is the difficult. But for your hypothetical patient, I will consider. Yeah.
Thank you.
Postgraduates, any question? Don't tell that you have got all about newer agents. Can you write an essay with the points we discussed today? Come on. Yes?
Just when they say you are advocated when I talked about this topic in Madurai, he also said for the seat on other antibiotic, then he also said the same thing. Will it still hold good?
Alphabet தான் A, one antique, one advanced. So பழைய சாதம் is antique. So there is no harm in trying, but moderation is the key. A girl complained that she got piled up 10 kilogram regularly introducing பழைய சாதம். So moderation is the key. My mantra is, you try something, if it works, try slowly and then see how your body reacts. But a properly preserved பழைய சாதம், no, don't keep it open and So a properly preserved பழைய சாதம் is some kind of a traditional probiotic prebiotic combo that should not do any harm unless you are extremely immunosuppressed, like a severe acute pancreatitis or a organ transplant or something. Intestinal ultrasound, who went to Hyderabad? Be honest, who went to Hyderabad to Kailvi madam and learnt? I was there for 10 minutes in Coimbatore conference. I think in Crohn's and in Crohn's especially, as a follow-up tool in well-experienced hands, because ultrasound is highly interpersonal variation.
Sir, actually in guidelines it is only an adjunct to MR. It is only an adjunct. It cannot be used for diagnosis. It is only an adjunct.
Like POCUS, no, not bogus, no, POCUS. Now, when they come, it's a nice thing to, if you serially monitor, if you know the landscape of a particular patient, I think you can monitor.
You cannot do ultrasound for bowel, all part of the bowel. There are certain areas which are visible, and for follow-up, if they are visible in ultrasound, it is quite
So only juniors are talking.
The ISG seems to be a geriatric population.
The junior most is here. Attend. Don't tell me you don't have any questions.
ISG.
Deepak, anga pakkathula apdi paaru yaradu. So whenever you are asked to, you are expected to talk, use the opportunity. So people will notice your name. That's how you.
Thank you, Dr. Basavani. I think the
panel, sir.
I think it was an excellent discussion.
Thank you.
Thank you, the panel, all 4 of you.
Thank you. Thank the chairpersons. Thank Dr. Basavani and all the panelists, and for a wonderful discussion. Dr. Hariharan also for his wonderful exposition on working up anemia. And also to take this opportunity to thank all the participants who have come in on a Saturday evening. I hope to see more postgraduates as well as members attend over the weekend. And I thank the hotel and our pharma sponsors for this, Torrent Pharma, for making this happen. And I welcome you all again to the next meeting, which will be a little earlier. It won't be in the last week of August. It will be a week earlier than that because of the Endocon, which is happening on August 29th. So it will be on August 22nd. The venue and the team will come down back to you shortly. Please join us for dinner. Think with this. Thank you so much.